we see the average TAT before applying the total lab automation was 3.9 hours. This I'm talking for the biochemistry, the parameters main. But after post total lab automation, the TAT significantly improved from the sample collection is 1.8 hours. So we have seen the significant decrease in the turnaround time after applying the total lab automations. And another things, because we get lots of data, whatever data we want, we can extract from the system. So we use this data not only for the how we are improving, but we use this data for the continual improvement of the laboratory. So when we see our delta check, it has come 18% is because of the collection error. So we got the percentage, okay, this percentage is because of the collection error. So we use this data and we go back and train our staff of the phlebotomy and the nursing staff to reduce this. So I'll just go through, it's a quick 2 slides. Again, if we see our QC failure because of the recalling of the results, because of QC failure, it has reduced to 0.1%, and rejection rate is also reduced drastically to 16% from 33%. So this is the last few slides. This is our live dashboard results. I should say the dashboard results. Here I can see the live data of the biochemistry divisions, how many samples have run, how many samples are auto-verified. If you see here, the 94% samples are auto-verified, how many samples have been held, how many outliers are there. So this we can display on the live basis, and all the technical staff will be aware what is happening on the live basis. So this is what the appropriate integration will do. Definitely it will be helpful for the industry. It will be helpful for the doctors and the technical staff. We can utilize the technical staff in a more efficient way, and we can take out the time where they are wasting the more time, and we can train them in much better way. And this is not complete. This is totally a teamwork. Without a good team, we cannot run this total lab automation. We cannot improve the quality. So thank you for your patience listening.
Thank you, ma'am. It was lovely listening to you. Any questions from the audience? Then perhaps I have a question. Yes, ma'am.
Yes, ma'am.
I have a question too.
Yeah, ma'am. Please.
Somebody can give my mic.
I don't have a question. It's just a comment. Lab automation makes it sound very easy, but believe me, to get to that level of auto verification is a very tedious, very long, and very interactive process. So please don't think that biochemistry is all auto analyzers.
I agree, ma'am, totally. That's what I told the last slide. It cannot be done without a good team. Means how much automation, what we do, without a dedicated, committed team, laboratory team, it is not possible.
And each and every analyte has different those markers of red and yellow and green and all the others.
So it will not a replacement of anything. It will be a more surety if results are visible to us. Thank you.
Yeah, ma'am, my quick query was, during your process mapping, you identified pre-examinations, examinations, and post-examinations. Here, basically with automation and your streamlining of the process within the lab, you've managed to save around 3 hours.
Yeah.
Right, around 3 hours. So how do you think you could, your suggestions and opinions to reduce the time pre-examinations regarding the sample labeling? So why can't we have, rather than the manual writing of numbers, the patient's one ID number is generated, and that barcode can be just transferred on.
Yes,
right?
that study was taken way back in 2016 to understand. Even we have the analyzers, the systems where we are lagging. So that study we have done in 2016 to see what the process. Then we have implemented. Now we are doing every year. We have implemented the barcoding. We have implemented at every area. Because of the short of time, I cannot say.
And once the samples are processed, it's getting automatically shot onto the respective.
Yes, it is getting automatically sorted. And even if I want to repeat the sample, I can trace from the system where my sample is lying down, because everything is barcoded. That whole rack is barcoded. Otherwise, earlier we have to run, the technical staff has to go and search the sample where it is. So it will take more time to find out the sample. Now we can see in the instrument manager where my sample is lying down, exactly in which rack, exactly in which position. So it is actually easy for the technical staff also, and definitely it is going to finally affect the patients. So it is helpful.
What about critical results reporting to the clinicians?
We have a hospital LIS system, so it will get auto-verified and they can access it through their system and we can send the reports also. So they can access all the reports. It is all passed, can go through all the reports in the system itself.
Thank you.
Thank you.
Thank you. Thank you, ma'am.
Thank you, ma'am, for this very insightful talk. Now we come to the last but not the least. The topic that is digital morphology, time for center stage. And we have with us a very erudite speaker, Dr. Anil Handu. He is a principal director of hospital laboratory services and senior consultant hematology at the BLK Max Super Speciality Hospital. His previous affiliations include the Department of Hematology, Sir Gangaram Hospital, Medanta, the Medicity Hospital in Gurugram. He is trained in the immunophenotyping of hematological neoplasms from Tata Memorial Hospital, Mumbai. He has done his fellowship from King's College Hospital, London and Westmead Hospital, Sydney, Australia. He has more than 20 years experience with expertise in flow cytometry, immunophenotyping, stem cell technology, molecular hematology, HPLC, just to name a few. He's also a postgraduate teacher in hematology at Sir Gangaram Hospital and now at BL Kapoor Memorial Hospital. He's been a guest speaker in various international and national conferences and has more than 35 publications in national and international journals of repute. I welcome Sir on stage.
Thank you. Thank you for the kind introduction. And I promise you, I'll not move more than 15 minutes. And I put a timer for myself as well. All right. So, yeah, so that's the presentation. What I have, this is the place where I work in Delhi, BLK Max Super Speciality Hospital. Acknowledgements to the team, who work at the back end and ensure that I'm able to give you the information that I'm sharing with you today. I have no specific disclosures to make. And this is how I have outlined my session. So I'll give you some hematology testing scenario quickly. We'll talk about the journey of a complete blood count or a full blood count sample. We'll talk about digital morphology. What is the need? Why are we even talking about it today? We'll give you some principles about it, some information about artificial intelligence and our experience on digital morphology platforms. So if I ask you a question, which is the most commonly ordered test globally, what would be your answer? CBC, obviously. More than 30% of the prescriptions globally, and this is already mentioned very clearly in world literature, more than 30% of the prescriptions, a CBC will be asked for, whether it was really required or not. We'll not get into that debate, but that is something which is being asked for every particular case. Why am I emphasizing on that? The question is, what happens to a CBC sample once it reaches the lab? Once it reaches the lab, let's have a quick recap how the entire thing works. The sample gets into a hematology analyzer. I'll show you a picture later, in which we either use electrical current, we use either light scatter or radio frequency to analyze the cells, to count the numbers. And we can also actually get a lot of data or information from the analyzer itself, which will give us information regarding what kind of cells are we dealing with. And this is a classical picture, which is there in Popke, published way back in 1976, wherein they showed us how the entire information would, really go. You would have the sample, which would be sucked in, and it will be divided into two halves. One half will go into the WBC chamber, where WBCs will counted. The second half will be converted, it will be taken into the RBC chamber or the RBC platelet chamber, where you will count the RBCs and the platelets. And subsequently, the RBCs will be lysed, hemoglobin will be taken out of that, and you will measure the hemoglobin. And all this data will eventually get collated and get into it from an analog signal to a digital signal, put into a computer across to you, and you will be able to analyze, right? So if you look at a cell counter, what was your aim? The aim of your cell counter was pretty simple. You wanted to reduce manual labor, and you wanted to reduce the work of reviewing your smears. That's what your target was. But at the same time, the issue is you do not want to miss a case. You patients where you would want to see a smear as well. So if you look at a complete blood count sample and you look at its journey to a result, how does it work? You run the sample in the analyzer. It's negative for any flagging or anything which is like abnormal within the sample. you just report it out. However, if you have a positive case wherein there is some flagging of some kind, you actually review a peripheral blood film or do whatever tests necessary are required to be done, and then finally report. There's also a third possibility where you have an error of some kind within the instrument, which gives you an opportunity to either review the clinical details, the sample, or the peripheral smear, and finally report. So in the end, what are you trying to do? You're actually sitting down and examining a smear, or reviewing a smear, or scanning a smear, or whatever you may want to call it. The bottom line is you're looking at morphology and giving the reports out to the patient. Now, when you do a review, there are certain principles which you need to keep in mind. The most important issue is not every time will you be available. For example, if I want to review a smear today here, I'm sitting in Calcutta and somebody else has to do it in Delhi. Maybe somebody wants an opinion from me only. What do I do? In such a case, I would have an access to a digital image and I would actually be able to give that information out. So keeping that in mind, if you look at conventional microscopy, this is how it would go about. You would need to have a microscope, you would need to have a smear, beautifully stained, etc. Put it onto the microscope and view it. And once you view it, obviously you need those counters, tuck, 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 and finally you get your numbers and you are able to actually give out the results. Now let's say when you do this, what all challenges do you face? Lots and lots of smears, lots and lots of reviews, lots and lot of work. And at the same time, you're not only looking at peripheral smears. There are lots of other things which you have to do potentially at the same time. So under such circumstances, the review takes this kind of a course. It goes through an analyzer, everything okay, you release the result, doesn't go through, you go through the analyzer and you find something abnormal, you get it across to the technologist, he gets it across to you, and you might eventually take a review from somewhere. Now, when you do this entire activity, this is all manual process. Now, let's say, what is the next thing that we can do? We can actually digitize the whole thing and have what is called the digital advantage, or the digital cellular morphology advantage. And in today's day and age, with the artificial intelligence, actually, as a part of the entire process, you can collate the information, the demographics, the information from the biochemistry, some microbiological data, and you might be wiser when you are actually looking at the peripheral blood film and deciding even when you want to have a peripheral blood film done. So we have had this opportunity of installing the instrument in our center. We've been now using it for more than a year and a half now. And this is how the digital morphology comes in. Just as the way when you see a book, you open a book and you see an atlas of hematology, you see pictures like that, and you are very confident when you're reporting it out. All right, so what do you do? In a classical ideal way, you look at a CBC for a report, you actually look at the morphology also and collate the entire data. When this entire data is to be collated, how will you actually really be sure of going ahead and making a smear or not making a smear? Fortunately for us, there are enough guidelines available from ICSH, which most of us follow and make our smears and appropriately give our information out. So that's what we did in our center also. We had the concept of making a smear. Fortunately, again, for us, the smear could be made on the analyzer itself, a digital instrument on which the smear beautifully was done. It was stained properly, and then put it across into the instrument called MC80, in which the images were taken. And these were high throughput images, which were at oil immersion lens, and they could be seen from anywhere across our network. And I'll not get into details of what exactly do we talk about in terms of the technology, but it's nothing but a microscope which is taking images, and you are actually storing it in a local server. And this is how the, technologically they are expected in this particular instrument, MC80, it's supposed to be better. Now, was it all a very simple, plug and play kind of a thing? The answer is absolutely no. There are lots of setup challenges which we had. And in this setup, one thing which came handy was this particular article, which was about digital morphology setup itself. And importantly, in all of them, if you notice, it very clearly says that you need to have your pre-analytics and post-analytics and etc. other things into picture very clearly. Only then can you get your images properly. This is how it was. You can see the picture on the left. Obviously, this staining was so poor. And as the staining progressed and became better, we were able to get better and better images. This is how the images turned out to be better. Beautiful images right in front of you. And this, again, you could access from wherever you're sitting in your respective chambers. I'll just show you quickly a few case studies from red cells. The usual, the normocytic and the normochromic ones. The analyzer itself is actually able to pick up and analyze. It's got artificial intelligence into it. And once it does, the normocytic, normochromic red cells come in front of you, and you are actually able to get percentage of your hypochromic or percentage of your microcytic cells as well. Like in this particular case, we could actually pick out the microcytic and the hypochromic cells, and they could be counted as well, and you could get relative percentages. And this is how the pictures would come up. You could even fade out the background and get to identify your hypochromic or microcytic red cells. Again, hypochromia, pretty obvious. The hypochromic cells could also be emphasized. Macrocytosis, you have people who look at morphology on a daily basis. You get fascinated by things like, basophilic stippling. Just look at the picture here. It was picked up by the instrument itself as basophilic stippling and presented to you. There were other images also. I have, for the shortage of time, I have not included all of them, like Cabot rings and etc. Let's look at the WBC series now. In the WBC series, obviously, we were looking at the neutrophils, the usual ones. Again, very beautiful pictures which come in front of you. And it gives you relative counts as well. The biggest question which was asked in one of my presentations previously was, how does it correlate with your regular morphology and your analyzer? So this is the data which we have from our own center, where we have shown how it correlates with respect to, this is the total leukocyte count correlation, and this is the neutrophil correlation. This is the correlation of lymphocytes, correlation with monocytes, eosinophils, and of course the basophils. So when you look at all of them, you realize that your correlation happens best with neutrophils and lymphocytes. There is relatively less correlation with monocytes, and of course the cells which are the least in the number, that's basophils. The correlation on the digital morphology itself also will be a challenge. Now to show you a few cases of WBCs, this was a 66-year-old diabetic lady who was semi-comatose, wheeled into an emergency at nearly 11:30 in the night. And a CBC was sent, and obviously no doctor is available in the lab at that moment of time. I got a call, I was asked, what do you think this is? What did I do? I just asked for the digital morphology. I opened up, and what I could see was toxic change as well as the presence of Dole bodies. I hope you are able to identify them from the distance over there. And I said, she's in sepsis. Please start working her on the sepsis part of it. Obviously, she was worked up and she became better a few days later. Again, these two cases which I want to show you, in the first one, I'm sure people who are from pathology background and hematology who practice the hematology usually. Can you tell me the name for this neutrophil up there? It's a Botriard neutrophil, right? This is usually seen in cases of megaloblastic anemias. And of course, we also saw the cells like these, which were picked up by the analyzer, by the digital morphology analyzer, and labeled and gotten in front of you. And this was what? The large granular lymphocytes, a case of rheumatoid arthritis. Another case where we found so many abnormal cells or blasts, and they were again counted by the analyzer upfront and given to us, and we were able to give information as quickly as we could, and this was a case of ALL. Another case where we found the immature myeloid cells. You talk about the IT ratios and stuff like that. The instrument was able to pick up the immature myeloids, and we were also able to pick up digitally all the immature myeloid cells and give across as a count. Again, a case of leukemia. This was a case of myelomonocytic leukemia. You can see the number of blasts in the promonocytes which have been picked up. And in this case, just to show you quickly, another one where you are seeing the entire spectrum of cells. You see the entire spectrum of cells, and then you see the presence of eosinophils, the presence of basophils, and the presence of this large, giant platelet. What would be your diagnosis? The obvious diagnosis is a myeloproliferative neoplasm. It was PIMF. Just to give you a quick look of 180 cases that we have visited so far, especially on the hematological malignancies. They were across the spectrum of the age, but the digital morphology platform was able to pick it up in most of the cases, and we were able to give answers very beautifully. This is just a few pictures to show you, to relish the images part of it, how it turns out on a typical digital morphology analyzer. All the series, especially the WBCs, and the left shift and the hairy cell over there, which you can see, the myelocytes, the abnormal or atypical lymphoid cells, and you have this faggot cell on the right. Quickly into platelets. Platelets, the most controversial, but least morphologically, glamorous, if I may call them so. But if you look at this platelet, these platelet cells over here, you are able to identify their cytoplasmic complexity as well. And of course, the platelet satellitism, which we would usually see in the books only, we see it now on the slides as well at some point of time. There's another very interesting channel within this analyzer, which is called the Platelet Pro, in which you are actually counting the cells in the area which is at the edges, at the feathery edges, and you're able to pick up your platelet clumps. And it actually helps you in all the cases where there is pseudothrombocytopenia. We've also done a correlation for platelets, both on usual morphology and the morphology on digital, and found them equally reasonably good. Again, case studies on parasites. I'll quickly go show you some interesting case studies here. This is a study, a case in which we had dengue, and you can see these abnormal or atypical lymphoid cells, what they're called, the downy cells. And in this, in addition to this, there was another case where you saw the presence of these parasites. All of these are malarial parasites which you're seeing. Again, picked up by the machine itself. Initially, was not picked up correctly as a malaria, was picked up as one of the artifacts, but we eventually had to sit down and actually classify it as a parasite. This is the image of a schizont, again as images of the gametocyte. And this was also picked up by the analyzer because the analyzer also gives you the information about infected red blood cells. Again, another case of infected red cells, malaria itself. So what was our experience on this instrument, the MCAT that we have had? I would say it was a learning experience. We had a lot of learning in this. We realized that it's not that just you plug and play. There were a lot of stuff which we needed to standardize and get across to everyone. And then it's still an ongoing activity. What did I like best about this particular instrument? The best that I liked about the instrument was this possibility of using the software at a distance. And in one shot, I'm actually able to look at the graphic details, and I'm also able to look at the morphology of the picture. So Lab Expert Client software, that's what we use, and it gives us all the information. So to finally summarize, it helps us to standardize our reports. We're actually able to look at the slides from a distance as well. It automates our expertise, and at the same time, distance is never a barrier. And it also helps us to integrate this as a part of our, reports in case we are wanting to, and especially when we are wanting to present in places like these. Last but not the least, it is the man behind the machine who is extremely, extremely important. Don't just think that you will get this machine and you will get to know what a blast is like. You will need to get trained. You will need to assure that you've done your staining properly. You've had, being comfortable with your instrument the way you're expected to be, and only then ensure that it becomes a part of your routine workflow that can you do this work. Thank you very much, and I have completed right on time.
Could somebody pass the mic to ma'am?
First of sounding a bit different. I want to ask you, and you about question is that you say that we need to do the staining properly, right? So is the staining done on the instrument, or is it done manually? I am a bit confused about this.
Okay, so there are two ways to do staining actually. One, you can do manually, not for this instrument though.
Not for this.
Not for this
For
instrument.
this, I'm asking.
But for this instrument, there is an automated stainer, automated slide maker. Both of these have to be there in your center. Only then can you proceed with this instrument. Now, the biggest challenge is we had the automated stainer and automated slide maker beforehand. This came as a
This came
attachment later on.
Yes.
And we were already staining, by the way. And we were having reasonably good staining. We never thought that our staining was not good. But you know what happens? I don't know how many of you have actually faced the camera, when you go for a recording or something. Have you ever faced the camera in a recording room?
Yes.
Yes.
So you think you will just walk in and they'll just put a camera in front of you and you will start talking and your face will glow and you'll look very beautiful and nice and all that, right? But that doesn't really happen. When you actually are going ahead for, some kind of a recording somewhere, the first thing they do is they put foundation, just the way all ladies would know about it, foundation and all that rubbish on your face, make you look better or whatever. Sorry for the word rubbish. It's not rubbish. It's something which is more important for some of the people. Anyway, so they'll make you look good. And only then when the camera focuses on you, you look better, right?
That is what
This is what I realized with digital morphology. In digital morphology, आपकी शक्ल बहुत important है. उस photo, उसके अंदर कितनी अच्छे से आपने अपनी photo खिंचवाई है, that will depend upon how have you made it up nicely. So staining is your biggest challenge. Slide maker and staining has to be your biggest challenge, which has to be sorted. Photo तो वो ले ही लेगा. That will take the picture irrespective of whatever you think. But if you do not do your staining properly, and if you do not, make sure that your instrument is in sync with your staining, your artificial intelligence will not work. So you have to be very careful what you do.
Again, it's an automated platform, the slide maker, right?
Pardon me?
So the slide maker is also an automated slide maker.
Yes,
And the staining is also automatic. So
Yes.
where does our expertise come in?
where does our expertise come in?
In this slide maker and the stain.
So for the slide maker and the stainer part of it, to design that algorithm of staining and making sure that you get the right kind of staining, it is you, the human, who has to intervene. And once you've done that, even after when you set up your artificial intelligence and you make your instrument learn from you, you will define, okay, this cell in this staining is a monocyte. In this cell in this staining is a lymphocyte. This cell in this staining is a blast. So like that, you train the instrument, and then once the instrument gets trained, it gives you information.
I have just one word for this. Hematologist ka ye netra sukh hai.
Thank you.
Do we have any more questions?
Sir, I have a question. Sir, the monocyte, you told that linearity was not good, no?
Fantastic. You picked it up despite me quickly
Yeah,
going through it.
I know that the police and limbs will give better results, but
Yeah,
can you say that which one was better, AI or the manual?
Okay. So now the biggest challenge what we have is when we look at AI versus manual, first question is, when you identify something as a monocyte, was it truly a monocyte? You know, so the biggest challenge comes there. We did a small little study on this and figured out that when we are trying to look at monocytes on the morphology, are we getting similar numbers in flow cytometry? Because that helps us to differentiate very clearly by putting up the markers there. So we realized that many a times what we think is monocyte is not a monocyte, right? It's actually maybe a myelocyte.
So AI was better, right?
Yes, so AI was better.
Thank you so much, sir. I even had the same error because the graphs which you showed, that was a 2 by
The
2.
last two graphs.
Yeah, it had a 3 by 2 and a 2 by 2 errors.
Yes,
So that's the same thing. So I think
Yeah.
sir already cleared that.
he already cleared that.
Yeah. Thank you, sir.
Thank you very much. Thanks, everybody.
Thank you, sir. Please do not leave as yet. So can I please request Dr. Pranati Gupta ma'am to come up on stage and felicitate our honored chairpersons and speakers? That's right. Madam.
Can I please request our speakers for this session, Dr. V. Ramasubramanian, Dr. Deepthi Jain, and Dr. Handu is already here with us, to please come up on stage. On it. No, Dr. V. Subramanian. Now, Tatik dao. Madam ke dao. Oh, he left. Can somebody please collect on his behalf? That will be great. It's nice to applaud even when the person is not there. Thank you so much. Dr. Deepthi, please. I think people would have been energized after that wonderful lunch from 6 Ballygunge Place. Thank you, Dr. Handu. Always a pleasure. Thank you, ma'am. So now we come to a very interesting juncture of today's Lapthon conference. So this session will be based entirely on the small things that make life worthwhile. And we need to know our little messengers. That is, we need to know our hormones. So the next session delves into the endocrine system. The chairpersons for this session are I'd like to introduce both of them. Dr. Deepnarayan Mukherjee, who's a consultant clinical and molecular microbiology in Woodlands Hospital, Kolkata. He is MD microbiology and FGID in infectious diseases from CMC Vellore. He is consultant in charge clinical microbiology, molecular biology, and infection control at Woodlands Hospital, and also at CK Birla CMRI and Bhagirathi Neotia Hospital, Kolkata. He is assessor for NABL and NABH at entry level and NITI Aayog, and a member of the IAMM, ISCCM, and IDSA. Can I please welcome sir on stage? Thank you. And our next person is Dr. Shubhanshu Mandal, who also requires very little introduction, but I must introduce him too. He is Associate Professor and Specialist Microbiologist at the Chittaranjan National Cancer Institute, Kolkata. And he has done his MBBS and MD in microbiology from West Bengal University of Health Sciences, followed by fellowship in general infectious diseases from CMC Vellore. He is ex-consultant and was in charge of the microbiology and molecular biology sections at the CK Birla Group of Hospitals, both CMRI and BM Birla Heart Research Center. It is a critical care infectious disease course he has done from the Indian Society of Critical Care Medicine. He has an infectious diseases certificate course from PD Hinduja Hospital, Mumbai, and he has done an antimicrobial stewardship course from the University of Dundee. He has also done a certificate course on clinical laboratory and ethics in good laboratory practices from the Indian Institute of Public Health, Bhubaneswar. He has also done a course with the European Society of Clinical Microbiology and Infectious Diseases Observership at the Lausanne University Hospital, Switzerland, as a young scientist. He is trained in molecular biology by the CDC USA, and he is a trained internal auditor of the NABL as per the ISO 15189:2012 standards. He is trained in WHO ICMR training program on mycology from PGIMER Chandigarh. He is a DNB faculty in microbiology and a life member of the Indian Association of Medical Microbiology, Indian Society of Medical Mycology, the Hospital Infection Society of India, as well as the European Society of Clinical Microbiology and Infectious Diseases. And he has published several original research articles in reputed international and national journals. So Dr. Mandal, can we have you there? Okay, you've taken your seat. So now without any further ado, I would like to introduce the first speaker of today's session. She is Dr. Moshini Shaikia, and she will be speaking on hypercortisolism, root cause analysis, adrenals always aren't to blame. Ma'am is a consultant biochemist and laboratory medicine and quality head of Apollo Hospitals, Guwahati. She is also the general secretary of the Central Committee of ACCLMP, which is the Association of Clinical Chemistry and Laboratory Medicine Practitioners. She is an empaneled NABL lead assessor and technical assessor both. She is an empaneled NABH assessor for entry-level HCO and SHCO, and she is an empaneled NABH assessor for medical laboratory certification program. She is an empaneled faculty of the new ISO standard, that is the 15189:2022, and she is a distinguished clinical tutor of the Apollo Hospitals Education and Research Foundation, or the AHEARF, and she is a faculty for DNBs and Apollo College of Nursing faculty. Also, she is part of the Foundation for Quality India as a faculty, and she is the director of the Assam chapter of the FQI. Ma'am has presented in many forums, both national and international, and published in various national and international journals of repute. Ma'am, please, the stage is all yours.
Thank you, Shamishta, for a very kind introduction. First of all, I would like to thank the organizers for giving me this opportunity to present before you. Since morning, I have been here listening to all the talks and speeches given by stalwarts, I must say. I'm really feeling a bit nervous to present, but I don't know what I will carry in front of you. But I would like to do justice to whatever topic has been given to me. Since the time is very short, that we are already running shortage of time, I will just quickly like to begin with. My topic, which has been given, is hypercortisolism, the root cause analysis. not always the adrenal's fault. So let's see, go to the definition first. It's a very simple slide I have made. It refers to the clinical state which is resulting from the excess tissue exposure to cortisol and other glucocorticoids. So whenever there is a very high serum cortisol level, we get excess in the tissues exposure due to cortisol and glucocorticoids. And if it is sustained, it results in the development of Cushing syndrome, as we all know. Cushing syndrome is a distinctive constellation of clinical signs and symptoms, and it is a very, very challenging syndrome, which is very difficult to diagnose. So here, at the very beginning, let's see how the classification goes. The endogenous and the exogenous Cushing syndrome. Let us first go to the exogenous one, which is totally the iatrogenic part, and surreptitious glucocorticoid administration will lead to the exogenous Cushing syndrome. And in the endogenous, we go to the ACTH dependent and the ACTH independent types. In the ACTH dependent type, Cushing's disease, as we all commonly know, this is mainly due to the pituitary corticotropinema. 70% of Cushing's disease syndrome is complementing to this pituitary corticotropinema. And ectopic ACTH secreting will contribute to 10 to 15%. In the ACTH independent variety, the adrenocortical adenomas, adrenocortical carcinomas, and the nodular adrenal hyperplasias are classified. Let's go a bit into the historical aspect. As we all know, this has been coined after the neurosurgeon Harvey W. Cushing's, who has published in 1912 about his famous patient with endogenous hypercortisolism. This is due to the pituitary adenoma, and it remains as a minute classic during that time. He has reviewed this in 12 such patients, and the first patient was named as Minnie, who was from New York and developed the syndrome at the age of 16. This is a picture of Harvey Cushing's. Now, a little bit of basics from where, as we all know, this is very basic, from where the cortisol comes. The hypothalamus releases the CRH, then it goes to the pituitary, stimulates the release of ACTH, then it acts upon the ACTH will act upon the adrenal receptors, and this will enhance the release of cortisol in the blood, and cortisol itself will have a negative feedback effect on the hypothalamus. So cortisol has a very peculiar property of maintaining a circadian rhythm, as we all know. The circadian rhythm has been studied in around 33 healthy individuals, where it has shown that the nadi level has been reached, that is the lowest level, which we call the trough level, has reached at around 12 or 18 hours, and it has come up and risen up to 8:32 or exactly from 8 to 9 a.m. This is the active phase, where the value is around 15.5 microgram per deciliter, then slowly declining towards evening and so on. So maintaining this circadian rhythm, the sample collection of this particular test is very, very important. Many of us working in the hospital setup, we find that we get many times very random collection of the samples. So when we have set the reference ranges, I don't know how much it is helpful to the clinicians about the random value, what is the interpretation, but whenever we inquire about the sample collection, it has been many a times found that it is, although the clinician writes it at 8 and 4 p.m., it is not so. When we go back and see, when we trace it back, we see that the nursing staff or other staff collects the sample at odd hours. Say, for example, after another 2-3 hours. So that gives a very wrong impression about the value which we are giving in the system. So this is the duty of each and every laboratory person, collector, as well as the reporting authority has to be very much cautious about reporting the cortisol values, morning and evening reports. So we have to maintain the circadian rhythm. There are various forms of hypercortisolism. The classic advanced Cushing syndrome, which is very much uncommon, and we will see what are the other forms. These are the subclinical Cushing syndrome, iatrogenic Cushing syndrome, fractious, cyclical, intermittent, and pseudo Cushing syndrome, which we will come in the next slides. A bit about the syndrome, where we can find many other the hallmarks of this Cushing syndrome, as we know about it: buffalo hump, moon face, lengthening of the skin, bruises, etc. So the diagnosis becomes very critical for us, and it is also very important how much the clinician gets the information from the laboratorians. So the diagnosis, first step of diagnosis should be, we should rule out the exogenous cortisol use by proper history taking. This is I have taken from the Harrison, as you all know. This is the algorithm management of patient with suspected Cushing syndrome, and which should be followed by all. And it has been accepted by the Endocrinological Society as well as the Italian Society of Endocrinologists. So here the algorithm per se, let us delve into the various aspects. First, the clinical suspicion should be ruled out, followed by the screening test. These are the first level of screening test. Then 24 hours urinary free cortisol, increase above normal 3 times, dexamethasone overnight suppression test, then midnight plasma cortisol, which is very much of the, also the midnight salivary cortisol, more than 5 millimole per liter. If there is any further confirmation, then we need to go for low-dose dexamethasone. So let us see in each and every slide how we are going into detail screening. So first is urine-free cortisol, which is collected over 24 hours on 2 occasions, must be considered positive. Here, the second is the dexamethasone suppression test, 1 milligram overnight or 3 milligram over 48 hours. That is 2 milligram into 2 days. And the third is the midnight salivary cortisol on 2 occasions. At least it is considered that 2 positive tests should be considered as confirmatory for the diagnosis. The urine-free cortisol is collected over 24 hours. That collection should be very meticulous. Less than 2% of the secreted cortisol usually appears in the urine as free cortisol. And 24 hours concentration, if it is less than 50 microgram per day, it is considered that the diagnosis of Cushing's is excluded. But the cortisol levels 3 times above the normal will suggest that the cortisol excess is there. So in this test, inter-individual variation in urinary free cortisol is about 50%, since we are taking it for 2 times. Then what are the pitfalls of this test? False positive results is usually due to improper timing. As I have said, the collection timing should be maintained. Concomitant use of diuretics we have to rule out. Depression, stress, and it is also found normal in the renal failure. Now, the use of this methodology, how to estimate this, we can go for the immunoassays, but there is interference of the immunoassay in the immunoassay test of the glucocorticoids. But the mass spectrometry is a more specific method for estimation. Now here the overnight low-dose dexamethasone suppression test, the rationale here is that if in the low-dose dexamethasone, the suppression of ACTH and cortisol production in the normal subjects is there, but in patients with Cushing syndrome, it is not found. Yeah, how do we go about this? 1 milligram of dexamethasone is administered at around 11 p.m., 10 to 12 p.m. The 11 p.m. is the exact time we can pick. And after the administration, the next day morning, 8 p.m. cortisol should be estimated. And the exact timing of sample collection should be very much under strict supervision. If there is negative cortisol value less than 3 microgram per deciliter or 1.8, it is considered that it is ruled out. So cortisol level is more than or equal to 10 microgram per deciliter. Most patients are diagnosed as Cushing syndrome. Now, the cortisol level more than 2 microgram may also be seen in stress, depression, OCP use, then obesity, drug use, etc. So this is a very, this syndrome there are many challenges in diagnosing this hypercortisolism. So the midnight salivary cortisol here, the 2 midnight samples are to be taken on non-consecutive days, and the patients with true excess endogenous cortisol production, the diurnal variability is lost. So the limitations here are the patient needs hospitalization. And the fifth one that we can also now go for scalp hair cortisol measurement, which is a promising and novel diagnostic marker. Now, the hypercortisolism is established by the first line screening, then ACTH measurement will come into play to determine the cause of high cortisol levels, whether the cortisol is ACTH dependent or non-ACTH dependent. Normal, moderately, or mildly elevated ACTH concentration will definitely lead to cortisol secretion that it is ACTH dependent. But ACTH concentration, if we find that it is less than 10 picogram per ml, then cortisol secretion is ACTH independent. This will be followed by the radiological investigation, CT and MRI imaging of the adrenal glands to rule out the adrenal causes. Now, rationally in dexamethasone suppression test, overnight high dose and multiple high dose, I'll quickly, because there will be 15 minutes allowed. So in low doses, what happens, the dexamethasone suppresses the ACTH and the cortisol production in normal subjects. But in patients with Cushing syndrome, it is not. So patients with Cushing's disease may show a suppression in very high dose of dexamethasone. So patients with Cushing syndrome from other causes like adrenocortical adenoma, carcinoma of the adrenal gland, and then there is production of ACTH which doesn't show that suppression is with high dose of dexamethasone. So to continue with this, the baseline 8 a.m. serum cortisol is first measured. Dexamethasone 4 milligram is administered orally at 23 and 24 hours, and the blood is drawn at 8 a.m. in the morning for cortisol estimation. So ACTH from the pituitary, here somewhat resistant to the negative feedback, as we all know, and the regulation by the glucocorticoid elevated set point for negative feedback. So non-pituitary ACTH secreting malignant tumors are highly resistant to this feedback suppression, and the suppression of the cortisol post dexamethasone and baseline urinary free cortisol from a 24-hour urine collection is obtained, which is taken as 2 milligram dexamethasone administered every 6 hourly for 48 hours. So at the end, urinary free cortisol is measured. So if the suppression of urinary free cortisol post dexamethasone administration is less than 50% of baseline, it suggests that the pituitary ACTH is secreted. So the failure of this is depression, on 2 minutes, severe stress, uncontrolled diabetes, and phenytoin medication. So I'll just quickly give the last slide description. So inferior petrosal sinus, this is the last, this is the gold standard for determination of the source of ACTH. This is an invasive procedure. ACTH level in the inferior petrosal sinus and peripheral vein is determined simultaneously. Once we are estimating the inferior petrosal sinus and ACTH, and on the other hand, we are taking the peripheral vein ACTH estimation. It can also be done following the stimulation with CRH hormone. And inferior petrosal sinus, the inference is that if the inferior petrosal sinus to the peripheral ACTH ratio is less than 1.4:1, then we see that diagnosis of non-pituitary source of ACTH is evident. That is, the ectopic ACTH production is there. And inferior petrosal sinus, if we find that the ratio is 2:1 or greater than without the corticotropin releasing hormone, and 3:1 or greater with the use of corticotropin releasing hormone, then the ACTH hypersecretion is definitely from the pituitary. So the localization of pituitary ACTH secreting tumors will be done by CT MRI. So this is a flow chart, how we have done it. So in conclusion, in addition to the suppression of stimulation, the testing methods of tumor localization should be used to document the cause of Cushing syndrome. And anatomical abnormalities are not always related to the functional abnormalities. When an adrenal source is suggested by CT or MRI, then venography with cortisol measurement in each adrenal vein has to be done. These are the next line of investigations. Then cortisol should be more than 50% or higher in one vein, and cortisol secreting adrenal edema is diagnosed. No significant difference in bilateral hyperplasia. So, seeing that it is a very complex situation where we find that the estimation is very much difficult. So, we have to be in coordination with the clinicians, what their need is, and the clinical history of the patient is very, very important to come to a proper conclusion. Thank you.
Thank you. Thank you for your excellent presentation. So I think we are running short of time. We can go to the next session and followed by question and answer session at the end, isn't it?
Yeah, or only one question.
Okay, only one question from the audience.
Audience is taking a post-lunch nap, I think.
Next, please.
Thank you, ma'am, for this excellent talk. So we move on to the next lecture. Our next talk is refining the diagnosis of pituitary neoplasms. This will delve into the pathology segment. Our speaker for today is a very popular person and again needs no special introduction, but I'll still try to do my best. Dr. Shukanta Chakraborty. He is a director of lab services, Thisam CMC Private Limited. He's done his MBBS from Archicor Medical College and MD from BJMC Ahmedabad. He is practicing histocytopathology in Kolkata for more than 15 years and reputed for performing all complicated invasive diagnostic procedures. He has multiple publications in various international journals, including a Springer book chapter to do with artificial intelligence in cytology. He is working as technical director, Thisam Diagnostics, histopathologist in Charnak and Kothari hospitals, and he is also a lead assessor in ABL. He also has started his own startup, which is the Doctors Diagnostics at Nagar Bazar, Kolkata. So I welcome Dr. Chakraborty on stage. Sir.
Good afternoon all. Today my topic is refining the diagnosis of pituitary neoplasms. So as we are running quite late of time, I will quickly go to the main discussion. This is anatomy of pituitary. So you can see the anterior pituitary is the hypophyseal hormone secreting neuroendocrine cells. In posterior, there is pituitary which are actually modified glial cells, and from above hypothalamus, that is axonal extensions of hypothalamic neurons which secrete hormones into bloodstream. And of course, there are stromal cells to support the entire gland. Now, what is need of treatment in pituitary tumors? All pituitary tumors don't need treatment. Non-functioning microadenomas, they are usually not requiring treatment. Functioning adenomas, due to production of hormones, they need treatments. And macroadenomas, of course, causing pressure effect. Of that pressure effect, vision problems due to pressure on optic nerve is the most common complication. And this is a picture of transsphenoidal route of pituitary surgery. I am coming next. So the non-functioning term is actually a description of clinical scenario to be given a disclaimer. And gonadotropes, and second common is corticotropes, which are usually non-functioning. And in patients younger than 25 years, immature P2-1 lineage tumors are also common findings in non-functioning pituitary tumors or pitnets. I'll discuss later why we are calling now pitnets. Now, what are the treatment options available? Of course, medications to shrink the tumor, and I have shown the picture, endoscopic transnasal transsphenoidal surgery. Another is open transcranial surgery, and of course, some radiation to shrink the tumor like external beam radiation, intensity modulated radiation therapy, and proton beam therapy. So next is anatomy of pituitary tumors. What I mean to say is pituitary tumors, if big, they come out of the sella. And contrarily, if paracellular or supracellular tumors, they go into the cellular region. So when we discuss pituitary tumors, we'll have to consider the tumors which arise from the surrounding areas of the cella, like supra and paracellular tumors, common are meningiomas, schwannomas, craniopharyngiomas, Rathke's cleft cyst, etc. So before going to the discussion of pituitary adenomas, I'll quickly flip through craniopharyngioma and Rathke's cleft cyst. Craniopharyngiomas are intracranial epithelial neoplasm arising from remnants of the craniopharyngeal duct or Rathke's pouch. They are WHO grade 1 tumors, non-malignant, predominantly solid with some cystic component, and they have two distinct variants, adamantinomas and papillary. And they are mutually exclusive from the cells of origin also. And the mutations of CTN NB1 is adamantinomas and BRAF gene is for papillary. And tumors with adamantinomas signature features are associated with high recurrence rate, morbidity, and mortality. These are on the left side, there is adamantinomas, and on the right side, there are papillary variants of craniopharyngiomas. Next is Rathke's cleft cyst. When symptomatic, it most often follows a chronic indolent course because it is completely malignant, benign, and a cystic tumor. And MRI image shows ovoid masses that are hypodense or iso or hyperdense and with solid cystic components. And pathology reveals columnar epithelial lined cyst filled with cholesterol-like contents. Next, I'll come to pituitary adenomas proper. So what WHO has done for me, they have classified pituitary adenomas, reclassified into pituitary neuroendocrine tumors because I'm presenting a pituitary neoplasm in an endocrine session. So in 2022, they have changed the nomenclature of pituitary adenoma. Now it is PITNET. So what's new in the WHO nomenclature? I'm mostly inspired, my talk is mostly inspired from the WHO 22 classification of pituitary neoplasms. So if there is distant metastasis, that is a very significant cause of calling a pituitary adenoma a malignant potential or pituitary carcinoma, which were earlier called. They are sub-classified depending on their hormone production. So by WHO 22, the first criteria of classification is from the cells of origin. And next comes the hormone secretion. Now, for pituitary tumors, invasion of surrounding structures, which I have already said, is like dura mater, sphenoid sinus, bone and cavernous sinuses. They may be associated with a higher risk of tumor recurrence and should be commented upon whenever possible. And this fourth edition has recommended the adoption of primary adenohypophyseal cell lineages rather than the type of hormones. Of course, the subtyping according to hormone secretion is also there. And the atypical adenoma term is removed. Now they are called high-risk adenomas. That means the tumors with uncertain malignant potentials. The adenohypophysis is composed of 6 types of cells: somatotroph, lactotroph, mammosomatotrough, thyrotroph. They are of PIT1 lineage, and corticotrophs are of TPIT lineage, and gonadotrophs are of SF1 lineage. And these tumors are subclassified into densely granulated and sparsely granulated tumors. Densely granulated tumors are more hormone secreting, and sparsely granulated tumors are more aggressive, likely because they present at a later date because their hormone secretion is less. And reverse is true for lactotroph tumors, which are more commonly sparsely granulated. Now, thyrotrophs and gonadotrophs, they don't have recognized subtypes. And posterior lobe tumors, their cell lineage is TTF1. And they are subclassified to spindle cell oncocytoma, cellular ependymoma, which is cellular ependymoma is a newer entity in WHO 22. And granular cell tumor, these are subclassifications of posterior pituitary tumors. Now, a comment should be made for tumors showing aggressive microscopic features like high mitotic count, high Ki67 index, and they are called high-risk adenomas by new WHO. This is the exhaustive classification list of 22, and a concise format of this is this chart. Adenomas producing growth hormones are there, adenomas producing prolactin is there, and adenomas producing TSH is also there. And of course, null cell adenomas which don't produce any hormones, they are also an entity. So, what are the reporting proformas? I'm not going exhaustive. What are the reporting proformas? First of all, summary of clinical and neuroimaging features, then microscopic description like tumor architecture, cytological features, like presence of fibrous bodies, Crookes hyaline change, which I have shown in the adjacent picture. This is glassy homogeneous hyaline deposits in the cytoplasms, and then cytoplasmic vacuoles, nuclear atypia, particularly when they are severe, and then admixture of ganglion cells, which are called actually mixed gangliocytoma and somatotroph pitnet. Admixture of ganglion cells are there or not, necrosis is there or not, macrophages and lymphocytic infiltrate is there or not, Rathke's rest, cavernous sinus. These things should be mentioned if they are present. And of course, mitosis should be counted and reported as number per millimeter square per high power field. This is Mangaram Island of Lakshadweep, which I visited before our PM's visit. Coming back to the pitnet. What are the histological subtype? In the ideal setting, all pitnets should be stained for at least the 3 main transcription factors, like PIT1 or anterior pituitary specific transcription factor, TPIT, and SF1. And then staining for important hormones like ACTH, growth hormone, prolactin, beta TSH, beta FSH, and beta LH, as well as alpha subunit of glycotropic hormones. The importance of keratins is also there, and mostly CAM 5.2 keratin is used in IHC staining of pituitary tumors. But when the setting is not that ideal, 2 factors can be there. One is cost effectiveness, another is scarcity of tissue, because these are brain tumors. Tissue may not be adequate to go through all the stains. Then the approach is staining for the transcription factors or cells of origin, and then selectively using the hormones. Now, some histological pictures. I'll quickly flip through. This is densely granulated somatotroph tumors. They are most common cause of acromegaly, and they are composed of large cells with acidophilic cytoplasm, and there is strong staining cytoplasmic reactivity for PT1 and nuclear positivity for PT1, I'm sorry, and cytoplasmic for growth hormone, and CAM 5.2 keratin staining is also strong. Next is sparsely granulated somatotroph tumors. As you can see, they have chromophobic cytoplasm. They are also CAM 5.2 positive, PT1 nuclear staining, and growth hormone staining is there, but less than densely granulated. Next is mammosomatotroph tumor. They are likely densely granulated somatotroph tumors. They are composed of large cells with acidophilic cytoplasm and diffuse strong cytoplasmic reactivity for growth hormone and nuclear reactivity for PT1. And they also express prolactin. Next is gonadotroph tumors. They are also chromophobic, and they form sheets, ribbons, more like neuroendocrine tumors of elsewhere. Sheets, ribbons, etc., trabeculae, and SF1 strongly positive, GATA3 positive, and focal positivity of FSH staining. Next is, we must discuss some interesting topics about hyperprolactinemia. It is actually not due to always prolactin hormone secretion. Any tumor of sella, they interferes with the transmission of dopamine to the adenohypophysis from the hypothalamus, and this is so-called stalk section effect, which is responsible for moderate elevation of circulating prolactin that is regulated by tonic inhibition from hypothalamus. Due to lack of inhibition from hypothalamus, all cellular tumors can give rise to hyperprolactinemia. The tumor proper is secreting prolactin or not. This can be seen with any pitnet, what I'm telling, that does not synthesize or secrete prolactin, with tumors in the cellular that do not completely destroy the adenohypophysis, as well as with inflammatory condition or hypophysitis. And the term prolactinoma is so meaningless for histopathological tumor classification. This is a sparsely granulated lactotroph tumors, which is positive for PT1 again, for focally positive for ER, and they are secreting prolactin, which is giving nuclear staining. Next is TSH secreting tumors. One of the most important changes in the new classification is the emphasis on the pitnets of various pitnets which secrete TSH. They include thyrotroph tumors, immature PT1 lineage pitnets, mature plurihormonal pitnets secreting many of the hormones like this. And previously it was called that TSH producing tumors are aggressive with extensive fibrosis and invasive behaviors. Now it is known that fibrosis is, of course, a feature of TSH producing tumors, but this invasive or more aggressiveness was due to inclusion of only immature PT1 lineage tumors. Excluding that, other TSH producing tumors are comparable clinically with other hormone producing tumors. And an important differential diagnosis of TSH producing tumors is thyrotroph hyperplasia due to primary thyroid failure with hypothyroidism. There is, in this thyrotroph hyperplasia, there is complete cellular enlargement with no enhancing rim of normal tissue, which is found in tumors. So next is a thyrotroph tumor. The spindle-shaped cells, nuclear PT1 and cytoplasmic TSH. How much? 2 minutes. Okay. So these are posterior pituitary tumors. Pituitary-cytomas. They have this fibrous or spindly structure with TT1 positivity, and also S100 is positive. Next is a new entity. It is pituitary blastoma, newly mentioned in the WHO 22. This is a rare tumor composed of small undifferentiated blastoid cells, and they are positive for ACTH. Next is hypothalamic tumors, which comes to sometimes. They are hypothalamic neuroendocrine tumors, which are composed of hypothalamic neurons, and there may be admixture of ganglions. These large cells are ganglion cells, and these are admixture of ganglion cells and pituitary adenoma cells. Next is what are the relative clinicopathological risk of pigment tumors? As I already said, going outside the cella and as per the tumor cell lineage. And for patients with Cushing's, sparsely granulated tumors are more aggressive. For patients with pituitary tumor dependent hyperthyroidism, immature P2s are more aggressive. Patients with hyperprolactinemia, there is a complex interplay. So the rare densely granulated subtypes are aggressive, and immature P2s are always aggressive. So this is grading. Grading of pituitary tumors has nothing to do with morphology. This is absolutely radiological grading coming out of the cella, just destroying the floor of the cella. These are grade 0 to 4. So what is due next? After WHO 22, the development of a uniform staging system for pituitary tumors is left. This is our next target in classifying pituitary adenomas. So what is take-home message? Pituitary adenoma is now PITNET. Hormone-secreting tumors are diagnosed early and treated early. Cell lineage and hormone production both are important for subtyping and prognostication, and invasion of surrounding structure or distant metastasis is important, not proliferation index or Ki-67 like neuroendocrine tumors of other organs. So this slide is my alibi, because I may not be able to answer all your questions. Thank you.
Thank you, Dr. Chakraborty. Due to the shortage of time for this wonderful presentation, due to the shortage of time, we can allow one question from the audience. Is there any question?
Thank you so much.
Okay. So we can go to the next session. Thank you.
Thank you, Dr. Chakraborty, for this excellent presentation. Now we move on to the last talk of this segment, which is interplay of endocrine disorders and infections, mutual impact and interaction. This is from the microbiology perspective. And our speaker for this talk is Dr. Shantan Banerjee. He is Associate Professor, Department of Microbiology, AIMS Kalyani. He is MBBS, MD in Microbiology, DNB, DIP, RC Path, and FRS PH. He has also done his DM in infectious diseases from AIMS Delhi. His areas of interest include biosecurity, emerging and re-emerging infections, neglected tropical diseases, antimicrobial resistance, and HBV, HCV, and HIV, to name a few. He is a technical officer of antimicrobial resistance and consultant of antimicrobial resistance in the WHO SEARO. He is a consultant of infectious diseases in the Indian Council of Medical Research, that is the ICMR. He has a previous experience of being a senior consultant of infectious diseases at the Beleghata ID and BG Hospital, Kolkata, and was a director of clinical research one day sooner and assistant professor of clinical microbiology at the ESI Hospital, Kolkata from 2014 to 16. I welcome Dr. Banerjee on stage.
Thank you. So I don't know how much of interest is left, but I see a few microbiology colleagues and infectious disease people. So I'll just try to do justice to my topic. My topic here is to discuss about infectious diseases in endocrine disorders and endocrine disorders in infectious diseases. So basically, while exploring the different infectious diseases that occur in different endocrine disorders, we definitely start with diabetes. And we definitely start with the most common infectious diseases that occurs in the diabetes. But we will also try to, talk about certain uncommon infectious diseases that occur in different endocrinopathies and certain infectious diseases that results in different endocrinopathies. There are different infectious diseases we are getting. which results in certain infection, endocrinopathies. Definitely with diabetes, we get so many infectious diseases, out of which the most least diagnosed ones are the anaerobic infections, because we know that in most of our hospitals, even in the best of the hospitals, the yield of anaerobic bacteria is quite low. It's not just because our labs lack the anaerobic culture system, but also because of the pre-analytical error. The more the sample is exposed to the air, the anaerobic bacteria fails to grow in our lab. Okay. So in diabetes, we get a lot of anaerobic infections if we culture it very early and if we can reduce the pre-analytical, phase. So the most important ones and the most life-threatening ones are the emphysematous cholecystitis, most commonly caused by the Bacteroides and the GNARS, the gram-negative anaerobic rods. We also have emphysematous pyelonephritis, which may be caused by Enterobacteriaceae as well as the gram-negative anaerobic rods. The malignant otitis externa has been traditionally reported in the literature to be caused by Pseudomonas aeruginosa. But we have seen many cases of malignant otitis externa invading the cranial nerves and presenting as Grednigo syndrome, where we have found it to be mostly polymicrobial in nature. And there has been a lot of growth of Prevotella and other gram-negative anaerobic rods along with Pseudomonas aeruginosa. Probably Pseudomonas aeruginosa is a little bit overhyped in cases of malignant otitis externa. I would dedicate a little bit of extra time for diabetic foot and Fournier's gangrene in my presentation and about periodontitis. Regarding diabetes, regarding endocrinopathies causing infectious diseases, we can't, start the session without talking about diabetic foot. So diabetic foot ulcers is one of the most distressing and nagging problems of us. If it presents with necrotizing fasciitis and the patient lands in septic shock, it's a different kind of scenario. But in many cases, what we find is a nagging type of infection where, the healing is close to half of the cases, less than 40% cases appropriately healed. And the lifetime risk for diabetic foot for any uncontrolled diabetes or even controlled for diabetic type 2 diabetes patients is about 1/4 of all the cases. And 15% of these patients will require some sort of amputation. I'm not talking about entire amputation. It may be finger, it may be below the ankle, below the knee, etc. And it can cause necrotizing fasciitis, sepsis in about 10 to 15% of cases. Infections, as we were discussing, it is mostly polymicrobial in nature. And most commonly, the problem is whenever we get samples from the surgery OPDs, the swab samples collected from the OPD and goes to the collection center and is plated after, let's say, 2 or 3 hours of collecting the samples. Often we get nothing other than, the non-lactose fermenting bacteria, which is colonizing over it and which is overgrowing other bacteria. So often Pseudomonas, Acinetobacter, Burkholderia, etc. is over-reported and overrated in cases of diabetic foot infections. Now, what we have started at AIIMS Kalyani is sampling in the lab, and we have started getting an invasive sampling, and we have started getting many fastidious organisms and anaerobes from these diabetic wounds, which is actually helping us to cure cases. So I would like to talk a little bit about our success stories. I've just put a few photographs of our AIIMS Kalyani cases, which here we can see non-healing diabetic wounds, which are, which were there for years. Practically, this is one auntie of one of our MBBS students, and she had this wound, even it was worse, for more than a few years. Okay, these diabetic trophic ulcers. So what we found is following the European wound cleaning guideline and using weight relieving total plaster casts, the total contact casts, yielded best results for our diabetic wounds with trophic ulcers, and it responded very well. And what we would like to suggest is, if you are having this kind of nagging infections, diabetic foot ulcers, what we can do is we can go for one-stage invasive sampling. It has really helped us in the last 1 year. What we are doing now is, before going for corrective surgery or flap surgery, plastic surgery or whatsoever, we take the patient to the minority, we remove the upper layers, and we take an invasive sampling from the deeper bone or the deeper subcutaneous tissue. And accordingly, we give antibiotics, systemic antibiotics. We are most commonly treating the wound with hypochlorite solution, freshly prepared hypochlorite solution in our lab, which is actually giving very good results. And instead of using, fusidic acid or, this mupirocin, which only covers gram-positive bacteria, we are using more sort of wide spectrum antimicrobial agents like octinidim or sodium hypochlorite, which is giving us very good result with wet relieving by total contact casts. So total contact casts is often sometimes very disturbing for surgeons and other people who would like to see the wound, how is it behaving, and doesn't want the wound to be covered for 2 weeks. But believe me, we had got wonderful results in absolutely non-healing wounds by total contact casting and just simple sodium hypochlorite based, cleaning and silver or hydrogen peroxide based dressing. And we had numerous results of wonderful healing for diabetic foot. Okay. Regarding Fournier's gangrene and necrotizing fasciitis, these are two major things in diabetes that we regularly deal with. We have got ugly cases of Fournier's gangrene in our parents, and we know that, in our setup, in our setup, what we are having is, deserted parents in suburban or urban homes with their kids living abroad. Okay, so we are getting Fournier's gangrene in diabetic patients in very well-to-do families. Who are actually nowadays the adult diaper has become a kind of care of the day, and which is really becoming so. A diabetic patient without proper control of diabetes, secreting glucose and protein in urine, and making the urine a broth, and the diaper being unchanged for hours is becoming a culture media, this scrotum, and we are getting very bad Fournier's gangrene, which is actually nothing but necrotizing fasciitis of the genital area. And these patients, until and unless treated very aggressively with debridement surgery and, antibiotics covering gram-negative anaerobics, at least carbapenems, third-generation cephalosporins seldom work. And carbapenems, along with that, we are using some MRSA covering drugs, either linezolid or teicoplanin. So these are two cases which I wanted to emphasize. And necrotizing fasciitis also you must be getting. And as we are poor man's hospital, the public hospitals are getting much more necrotizing fasciitis. I believe many of the corporate hospitals are also getting that. Now, I wanted to emphasize on periodontitis. Now there is ample evidence which shows that periodontitis in diabetes is increasing in great number, and it has a spiral kind of action. If the oral microflora is changed, and if there is constant inflammation in the oral microflora, it is said to have adverse effect on the insulin resistance, and it actually increases the diabetes, which in turn increases the periodontitis, and it falls into a kind of, vicious cycle. So periodontitis in diabetes has to be taken carefully. And long-term chlorhexidine gargles previously were thought to alter the oral microbiota, and many of us were reluctant to give long-term, chlorhexidine gargles for diabetes patients. But now evidence shows that even reducing the microbial diversity in the oral flora, but reducing the microbial burden overall, is actually helping a lot in diabetes. A little bit talk on gut microbiota and metabolic dysfunction. This is something that we are trying at AIIMS Kalyani. Nowadays, we are trying to standardize a fecal microbiota transplant setup at AIIMS Kalyani. There has been enough evidence to show that the erstwhile described NASH, which is nowadays being called as metabolic dysfunction associated fatty liver disease, has been directly correlated with, altered gut microbiota, and altered gut microbiota leads to leaky gut, which leads to, flow of gut microbiome into the portal cells, and thus increasing the liver fibrosis, fatty liver and liver fibrosis. So it is said that, probably extrapolating the animal studies, if fecal microbiota transplant is done on obese and metabolic dysfunction patients, probably we might be able to treat insulin resistance and fatty liver disease in them. Let's see how it works. I won't go into the list of bacterial infections in diabetes. I would like to talk about a few other interesting infections that we get in diabetes. Multilobular, multi-site pyogenic liver abscess is something which is life-threatening. We get in diabetic patients, and which can be associated with mostly pyogenic bacteria like Enterobacteriaceae, and it can also be associated with gram-negative anaerobic rods. We see emphysematous pyelonephritis, which may be associated with the hypervirulent Klebsiella pneumoniae in diabetes, and you know that Asia is the leading continent in reporting hypervirulent Klebsiella pneumoniae, and which is initially it was thought to be the hypermucus producing colony variants, but now it is seen that even low mucus producing variants can be hypervirulent, and it causes unusual infections like, endophthalmitis in diabetic patients by hypervirulent Klebsiella. We get pyogenic meningitis, which is not a typical infection caused by Klebsiella, but in diabetes, hypervirulent Klebsiella has been seen in pyogenic meningitis. In brain abscess, recently we have got a patient with Klebsiella brain abscess in a diabetic patient who presented with, pyelonephritis. Klebsiella pyelonephritis was 1 week back, at the same Klebsiella isolate which we got from the brain about 10 days from the episode of the the pyelonephritis. So we get hypervirulent Klebsiella in Asia and in India. Tuberculosis and diabetes is something that I don't need to discuss in front of this august audience. But what I wanted to say is, unlike our previous understanding, diabetes is greatly increasing. I have worked closely in slum population, and beyond my imagination, the slum population in Calcutta, the urban slum population, is full of diabetes and full of obesity. But surprisingly, the COVID mortality was remarkably low in the urban slum population, despite of being the NCD rate quite high. When I flagged initially in 2020, in the first year of COVID, I was working with the WHO Southeast Asia Regional Office, where we modeled in the March that COVID is going to be very bad in the slums of urban slums of India. And we were very scared, But later on in 2021, what we understood is post-Delta also, the COVID did not affect the urban slums. The senior ICMR and government authorities, they told me that, NCDs are low in urban slums. People are not fat. People are non-diabetic. That's why people are less dying in COVID. But what we found later on is there is very high degree of diabetes in urban slums. And urban slums and diabetes is a breeding ground for the tuberculosis, which is becoming a very steep barrier for the National Tuberculosis Elimination Program. I won't go in detail of other infectious diseases that we see in cases of endocrinopathies, but I would like to highlight two important cases. One is, in cases of acute necrotizing pancreatitis, we are getting unusually high number of candidemia And we are having ERCP guided or EBUS guided samples from acute necrotizing pancreatitis, and we are getting unusually high amount of candida present in the acute necrotizing pancreatitis. So I would suggest that, we need to look into the previous guidelines, which says that, the fever of acute necrotizing pancreatitis, where you don't have a blood culture positive, you don't give antibiotics, fine. But we need to look into the non-culture methods of detecting candidemia in acute necrotizing pancreatitis, utilizing beta-D-glucan and all. And last, I would like to talk about half a minute about latest case of adrenal insufficiency. You know that adrenal insufficiency is described in so many infectious diseases, so many viral diseases, so many bacterial diseases, in disseminated tuberculosis, in Waterhouse-Friderichsen syndrome with meningococemia. I have never seen a Waterhouse-Friderichsen syndrome. But what I am seeing repeatedly, and currently admitted in my hospital also in Kollani, is disseminated histoplasmosis with adrenal involvement. And this is widely prevalent in West Bengal. We have isolated cases, we have isolated histoplasma isolates from adrenal gland. And it's a diabetic patient, a gardener in one of the farms in Horingata, just near AIIMS Kollani, middle-aged, no other immunocompromised, presented with disseminated, lymphadenopathy and heart failure with, anasarca. And we found the patient to be having severe hypoadrenalism, and the patient was diagnosed with histoplasmosis. So what I would like to say is endocrinopathies in infectious diseases and infectious diseases in endocrinopathies are very important aspects that we should bear in mind. I would happy to take, I'd be happy to take any questions. I suppose that maybe another 15-20 minutes more would have done justice to the topic, because
Thank you. Thank you, sir.
Yeah.
I think it's always mesmerizing hearing you. So I have one comment to make and one question. So one thing is that it's a very, very important finding that you have told us, that's regarding this candidemia in acute necrotizing pancreatitis. It could be eye opener for all of us, and we should think of something which we are not growing in blood culture.
Shubhranshu, yes. So it's a personal experience for me. I have lost my father-in-law just 1 year back, who suffered from an acute necrotizing pancreatitis, and being an ID specialist, we were trying to delay broad spectrum antibiotics as late as possible, as he was a CLL patient, and we were trying to be rational. And then, but unfortunately, his blood never yielded the bacteria. We did alternate day, means subsequent blood cultures, but he was very quickly positive for Candida tropicalis in day 3 of acute necrotizing pancreatitis, and he never recovered from it. We tried casofungin, etc. And then after that, my better half is a gastroenterologist, so we have been trying to take samples from acute necrotizing pancreatitis, and we are seeing unusually high amount of
These are tissues. These are
Candida in the tissues of pancreatitis, and as well as candidemia. Candidemia in acute pancreatitis is well reported.
Yeah.
In your cancer hospital and all, you might be getting also.
Yeah.
But unusually high in the tissues. So this is something I
It's
would like to flag.
new finding. But
I won't say absolutely new, but it's quite a flagging finding, and it was not a very common finding. I would like to hear experience of others. But
another
it's really
question,
disturbing. Yeah.
another question from my side for those diabetic foot ulcers. So you're giving weight reduction cast for 2 weeks. So do you giving any kind of systemic therapy, systemic antibiotic therapy?
So systemic antibiotics we try to avoid as much as possible, because most of these organisms that like we are isolating mostly non-lactose fermenting bacteria like Pseudomonas, where oral drugs we have only fluoroquinolones. Other than that, there is no other oral drugs, and fluoroquinolones are very commonly resistant in that. Otherwise, we are getting MRSA, where we have to give either cotrimoxazole or linezolid, where we are already having patients with neuropathy. So it's very difficult. So what we are trying, and we have been successful in all those cases that I have shown. These are all real life cases from my clinic. So we have not given any systemic antibiotics during these 2 weeks for all these healed cases. Okay, actually what we have done is we have emphasized on local wound healing. And when we put on total cast, yes, for those patients who had, visibly pyogenic and visibly purulent and foul smelling cases, we have given antibiotics, but for very less than 10 days. Whereas without giving the total contact cast, we have seen these patients kept on 2 months, 3 months of antibiotics without any result, with only antibiotic associated adverse reactions. So
Tried it with any other ulcers like pressure ulcers,
sorry.
bed sores and anything?
Bed sore problem is that the weight relieving is important. What total contact cast does is weight relieving. So in bed sores also, until unless we have a bed sore associated invasive infection, osteomyelitis of the pelvis or a deep subcutaneous tissue infection, truly speaking, local care and postural care is the best method of healing instead of, probably for us, the clinicians, giving IV antibiotics is the easiest way. And one dose of meropenem, one day of meropenem is is more costly than everyday invasive culture and good postural care, having 3 more caregivers per day for giving postural care. So I'm telling that, what we are practicing very easily, giving IV antibiotics, is actually much more costly affair than local therapy.
Sure. Is there any question from the audience? We'll allow one.
So what is your take home on anaerobic sampling? So I think this is a
Sir,
very
sir,
important thing.
Sir, my experience during my MD days, SRship days are very bad about anaerobic culture. But what we have done right now is now we are calling the patients into the lab, or we are sending our residents, or we are going ourselves into the OT, minor OT. So what we are doing regarding osteomyelitis, we have diagnosed a few cases of anaerobic osteomyelitis as well, where what we are doing right now is, before going for the final corrective osteomyelitis surgery, where it will go for debridement and putting the bone cement, before that we are performing one minor OT where we have an invasive sampling. We get the sample, quickly plate it over there, one for aerobic, one for anaerobic, both on simple blood agars is good enough, and one on McConkey. And then we decide about that. Now, sir, what the best thing that has happened for osteomyelitis is now we have the stimulant bone cement. Previously, we had to give only heat-resistant antibiotics, vancomycin, gentamicin. But with the arrival of the stimulant bone cement, we can give all antibiotics in that. So what we do is we decide on the culture before, and then decide what antibiotics to be given for the next, let's say, 6 weeks or whatever bone cement they want to give. Some prefer to keep it for months. Some orthopedic surgeons, and then we do. So that is actually increasing our healing much better.
Thank you. So I think we can conclude this session now. We can proceed for the next.
Please
Thank you.
go away, sir. Not yet. So can I request our other 2 speakers to also please come on stage, and can I please request Dr. Franklin to also come up on stage to give away a small token of appreciation to our chairpersons and to our speakers. I also invite on stage Dr. Moshumi Shaikia and Dr. Shukanta Chakraborty. Ma'am, sir, please. Sir. I think by now it has reached a place of utter somnolence. So can we please have more exuberance in the hand clapping? So, yes. Thank you. No, Dr. Shubhram, chairperson. Thank you. That's much better. Dr. Moshumi Shaikia. Thank you. Dr. Shukanta Chakraborty. And Dr. Shandan Banerjee. Thank you, Dr. Franklin. Now we move on to our next session. This is the section on medical legal aspects of laboratory medicine. The chairperson for this session is Dr. Colonel Taposh Rai. He is lab director and senior consultant microbiologist at the NH Rabindranath Tagore International Institute of Cardiac Sciences, Kolkata. He has about 17 years experience in this present institute. He has done his MBBS followed by MD from AFMC Pune. He has done his PG diploma in health and hospital management from IGNOU, New Delhi. He has been teaching undergraduate students at AFMC Pune and also taken classes as faculty of the School of Nursing at the NH RTIICS Kolkata. He is an examiner with the West Bengal University of Health Sciences. He is both technical as well as lead assessor for NABL. He is a life member of the Indian Association of Medical Microbiology and a life member of the Hospital Infection Society of India. He was associated with the Indian Army for 28 years and was posted in the areas like Leh and at the High Altitude Medical Research Center located about 11,000 feet above sea level. So I welcome sir on stage. Thank you, sir. Now, the first session for this is a much anticipated session, and we will soon see why, because it is going to be taken none other by Dr. Syed Mahmood Nadeem, who, from my own experience, I know delivers excellent talks on the subject, that is the medical legal aspects of laboratory medicine. He has done his MBBS and MD from PGI MEA Chandigarh. He is a histopathologist and aspiration cytologist, as well as a lead and technical assessor for NABL. He is the founder and course coordinator of the Neelam Path Lectures and Pages and the president of the West Bengal Cytology Society. It's with great pleasure that I welcome sir on stage. Please.
Start?
Yeah, I think.
Should we start, sir?
We'll start.
Can you hear me? So good morning. My job here is to wake you up. That's why it's morning. So at the outset, let me thank the organizers for asking me to be here, and especially Dr. Shushru, Dr. Travis, the whole team here, Sharmishta and everybody, and Shankar, Ashwani. It's a pleasure being here. It's an honor, and I'm humbled to be here. And see, basically, you've been hearing about endocrinology, microbiology, and so on and so forth. All these things are available on textbooks, on various aspects of things. This lecture is completely different. And basically, before I start my lecture, let me have you to understand the basic disclaimers. See, this lecture, please don't use this lecture as an element of legal advice. This is just basically a guidance. And welcome to Calcutta, the city of joy, the city of metro. You have metro overhead, metro under your feet, metro now under the water, everywhere. This is my ghar. So जब आप घर में आएंगे तो पार्टी घर में है तो पठान को तो आना ही पड़ेगा और जब पठान आएगा तो पटाखे भी होंगे. So with all the fireworks which you are going to see in the next 45 minutes or so, and let me tell you, these fireworks will be very surprising to you, and at times, sometimes a bit horrifying as well. So with this, we start the topic of the day, which is medical legal aspects of lab medicine. Subject never taught, but expected to know. It is very important for us to understand this very well. I would be sharing the entire talk or the PDF of it with everybody. Whoever wants the talk, can you just SMS me or WhatsApp me? I will send you the talk. It is very important for each one of you present here and the ones who are not present here to understand this subject. This is not given in the textbooks as we read across. So now you see, if I go to my daily work practice for the last more than 3.5 decades, this was my instrument of the day, my microscope. But today, this gets replaced by this. So this is the order of the day. And my white coat gets replaced by this, which is the call of the day. So I'm here talking to you from the legal perspective, trying to tell you and make you understand how you go about with your professional life. It's more important to understand this, as important it is to see the slides or to read hemograms. I happened to go through the entire curriculum of the latest update of NMC. Many of my friends were there who had basically drafted this curriculum. I also saw the latest curriculum for all the branches of clinical laboratory medicine, clinical medicine. And believe me, the closest I came to understand about anything which deals with medical legal aspect is the forensic medicine department and toxicology. Nowhere in the entire curriculum of MBBS, MD, lab medicine, DM, fellowship, anything about medical legal aspects of your work and your trade is told or taught. Everything starts here. When you have your graduation or your post-graduation ceremony and all the caps which lands back on your cap, it comes back to your head, and that's where you decide that your professional life is starting, and you are very ready to go onto the road, and this is exactly what starts with desperation, a desperation to win. And this desperation to win invariably leads to you crossing the line or trying to use the famous hand of God to try to climb the stairs, the ladders, and to achieve something which you really want to dream and to want to do it quickly. What you really don't understand is legal knowledge. Basically, you have no legal knowledge. And today, this topic is purely trying to bring forward to you all what you really need to know, the legal ramifications of everything. Life is very fine till the time the patient is very happy with you. The patient is considering you demigod, God, apni amake bachiye diyechin, and so on and so forth. Everything changes once he is dissatisfied. Once he is dissatisfied, everything is completely different. And then what you get in return, you get a legal love letter. It runs into pages, and it can be very horrifying to read if you're not used to it. So basically, here I am to talk to you about the law, which nobody will tell you, the legal ramifications of it. And believe me, you will be absolutely surprised. So if you look into the laws, which basically is regulating your day-to-day work, you'll be surprised to see it runs from the tort and the constitutional law, the Indian Penal Code, which recently has been changed, and now we have a new law, which is called the BNS, Bharatiya Nyaya Sanhita, which has already been passed by the parliament, but is yet to be notified. You have the Fatal Accident Act, the Dangerous Act, the Drug and Cosmetic Act, the Drug Control Act, Indian Medical Council Ethical Guidelines, which is now the NMC Ethical Guidelines, and guidelines to practice and use your basic, methodologies of terminations. The Dentist Act, Drug and Magic Remedies Act, medical termination of pregnancy. The Consumer Protection Act, which was 1996. Now you have a new one, 2019. You have the PNDT, the transplantation. And if you think this was all, you have something on the local front. You have got the medical ethics protocol, which is very stringent. Hardly you read it. Then on the local activity, you have the clinical establishment. which is also local as well as central. You have a central clinical establishment. And since health is a state subject, you have a local clinical establishment protocol, which is by itself a very long gazetted material. Then if that was less, you have the West Bengal Clinical Establishment Regulatory Commission. And then you have advisories from West Bengal Regulatory Commission coming every month. So you can see the number of advisories which comes every month. And then you have at the international level, Article 25, Article 12, International Arbitration Act. And then you have the WHO guidelines for ethical practice of lab medicine and forensic pathology. And I bet none of you must have ever read it or probably must not have heard of it. And this is exactly what you feel. You know, what is this all about? So this is exactly where you are. You are being regulated by so many regulations and you know nothing about it. So basically here I am basically trying to decode it to you in the simplest of the manner, in the simplest of the method by which you go back home slightly more careful and try to understand and practice your basic lab medicine a bit more carefully. So let us look at it from three perspectives: the law and its ramification, the precautions and preventions, and the provocative fear. We will go one by one. So first we start with the law. So basically it all starts with the torch law, the Tortuous Act. If you must be remembering when you were all small, way back in the 1960s, we were told there's a tort law. What is this tort law? Basically, tort law is basically trying to define negligence. You have done something wrong, there has been a harm, and you have to compensate in simplest possible way. This becomes the basis of all activity with regards to negligence or negligent activity. Now, the basic liability in tort law is threefold: a legal duty to exercise, a breach of duty, and consequential damages. This is a very famous case in the UK, the Bolam's Freeman's Hospital case, which basically defined for the medical fraternity what negligence was. This case was won by the doctors, whereupon a child died and the doctor was not available. The case was raised against the doctor. It was proven that it was not necessary for the doctor to be there for the child's life to be saved. But this became a basis of negligence. So how do we define negligence? Negligence is the breach of a duty caused by the omission of something or commission of something. That means you're supposed to do something and you have not done it correctly, or you're not supposed to do something and you have done that. That is basically negligence. And I would like you to understand this negligence is the basis of the entire legal activity which all of us have to undergo in our subsequent lives. So basically, you need to understand this slide is very important. Negligence basically is of two types: civil and criminal. Why is this important? I would like to clarify here for all of you to understand. In a criminal negligence, if proven, that is the only time the police can come in between. The police cannot arrest a doctor at all in a civil negligence, but it happens regularly. So this is where you stand to understand the law. If you understand the law correctly, if you have made a wrong diagnosis, it is a civil negligence. The police cannot arrest you, by no means. What all can happen is police can hold you back to prevent any civil issues with regards your health, your life, but cannot arrest you. It is only in this case of criminal negligence where, with certain criteria, which I'll come to in the few slides now, where the police can arrest you. So this is something which you need to understand very well. So basically, what is civil negligence? Malpractice, deficiency service, and criminal is gross lack of competence, something which you've done absolutely wrong. And that is exactly what is criminal. So basically, this is where the Supreme Court came in the picture, because we were having, before 2004, a lot of doctors were getting arrested for small things. The Supreme Court came into the picture, and in the famous case of Dr. Suresh Gupta's versus Delhi, where the Supreme Court gave the verdict very categorically the legal position was quite clear and well settled that whenever a patient died due to medical negligence, the doctor was liable in civil law for paying compensation. Only when the negligence endangered life, this is where the IPC 304A came into place, and that is where the criminal negligence could be put into place. Otherwise, for all practical purposes, a doctor cannot be arrested. So if anybody at any point of time tries to arrest you, you can immediately take a legal opinion and immediately get an instant bail. So this is one thing which you need to understand very well. Again, in the Jacob Matthews case, again, the Supreme Court reiterated the fact that you need to understand negligence has to be proven criminal before a doctor can be arrested. Now, the Delhi High Court categorized very clearly what are the criteria and the level of negligence. You can have slight negligence, you can have ordinary negligence, or you can have a gross negligence. And this was again reiterated by the Supreme Court. So basically, this is where we understand res ipsa loquitur, the thing or the fact speaks for itself. The error is so evident that the doctor has to prove his innocence. For example, amputation of the right leg instead of left, and so on and so forth. Operating on Sunita instead of Kavita. I mean, fine. This is exactly where things, but here again, please try to understand the Supreme Court has been very nice to us. It has laid down very clear-cut guidelines. And this is where we need to understand, according to the Supreme Court, in general, a doctor's innocence is presumed. It is the complainant who has to prove negligence. You don't have to prove yourself that, I am safe. It is the complainant who has to come and prove that there was an element of negligence. Otherwise, by default, you are innocent. And this is what you need to understand. Please understand this very well. The Supreme Court clarified very clearly in case of criminal negligence. You have made a criminal negligent act. It is very clear. Here again, the Supreme Court says you cannot be arrested. You can only, an ordinary person, suppose an ordinary person is driving, he's under alcohol, he does rash driving, and he goes with an accident and kills somebody. This is gross negligence. He will be immediately arrested under under 304A of the IPC or 106 of BNS. But for a doctor, if he does a criminal negligent act, he cannot be arrested immediately. The first-class magistrate, or for that matter, the investigating officer, has to approach another doctor who has to give in writing that according to him, this particular thing was grossly negligent. Only then the doctor can be arrested. This is exactly the Supreme Court saying that before you arrest a doctor, there has to be a second opinion from a person in writing under the behest of a first-class magistrate or the investigating officer. Only then. The police cannot come in straight away and arrest you. This is your right. You need to understand this very well. And this is very important. Now, this is where we come to now. 2023 December, the government passed on this new bill, which is the BNS Bharatiya Nyaya Sanhita. We need to understand this because there's a lot of confusion among the doctors, whether the doctors are within this act of this bill or not. So basically, if you understand, 3 old bills have been completely changed. Earlier, now we have the Bharatiya Nyaya Sanhita, which has changed. The IPC is no more existing. It is now the Bharatiya Nyaya Sanhita. The Bharatiya Nagrik Sukh Suraksha Sanhita, which the Criminal Procedures Code has been removed. So CRPC is no more there. Now you have the BNSS and the Bharatiya Saksha Adhiyam. This is another one which has come in. This is Indian Evidence Act has been removed. And now we have these 3 new laws, which will be come into act once it is notified. So we need to understand what about this. Please understand this basically is replacing IPC. Where does IPC come in? Where there is criminal negligence. So this here you have to understand that in this BNS section 106. Now let me make you understand this very well because you need to understand this well. Basically you need to understand in BNS 106 for any criminal negligence, you will be arrested, imprisoned for 5 years, rigorous or otherwise. Alongside that, you have to give a fine. This is for the common man. But for the registered medical practitioner, please mind my words, RMP, 5 years is not allowed, only 2 years for doctors. So 2 years for criminal negligence, if proven, 2 years of imprisonment and fine for doctors. This is the new thing in this new law. In the new law, for all other criminal negligent act, which is being done by anybody else other than the doctor, 5 years of imprisonment and fine. But for doctors, 2 years of imprisonment and fine. Another thing which is very important here is this special provision is only for RMP. Who are RMPs? The ones who are being registered in the National Medical Commission Act 2019. Everybody and anybody is not included in this. So all the allopathic doctors are getting exemption. Anybody else practicing alternative Indian medicine, dentistry, homeopathy, Ayurveda, doing all those bridge courses, carpenters becoming orthopedic surgeons. No, you are not getting exemption. Only the RMP gets exemption. So this is very important. So only registered medical practitioners, if found to be doing criminal negligent act, will be imprisoned only for 2 years. Everybody else will go for 5 years. Now we come to the summarizing part of it. I've already told you what it is all about. Now we come to this. Consumer Protection Act. Here is where the civil negligence comes in. Up till now, IPC, BNS dealing with criminal negligence. Consumer protection, you can see it, 1986, this became the law. And once it was notified, we came to understand what are the services in consumer protection. If you look at the services, look at it very carefully, you will realize medical services is not included here. In 1986 CPA, medical services was not included. So we were very happy. Doctors are not under the CPA. It was not like that. 1995, okay, fine, let me first finish this off. What does this CPA basically means? What is services? Services is basically there is a service provider and there is a consumer. Only when these two things exist together, services will be defined. And another thing is CPA is only applicable when there is some basic fee which is included in this. If there is no fee, there is no CPA. So all free services which are being provided, there is no Consumer Protection Act coming into picture. So that is very important. Those rendered free of charge, CPA cannot be put in. So if you are giving any free advice to anybody, giving any free prescription to anybody, you're not taking any money, you are not in the purview of CPA. This has to be very clearly understood. Even if you take 5 rupees and it is proven that you have taken a fee for it, you are under CPA. This is very important. Now the point is very clear. In 1995, the Supreme Court, in the V.P. Shanta's famous jurisdiction, it gave a verdict saying, doctors are providing a service, doctors are taking a charge, so why aren't they in the CPA? This famous verdict pushed us into the CPA, and since 1995, the medical fraternity is coming under the ambit of Consumer Protection Act. And so we have to be very careful. And Consumer Protection Act is only for civil negligence. The moment criminal negligence is proven, you go into the IPC 304. Now, this is what it talks about, negligence, how you have to prove it, that is all about. Now we come to the new version of it, CPA 2019. When this was being drafted, the Indian Medical Association put up a petition with the government saying, please do not include medical fraternity in CPA 2019. The politicians were very happy, they wanted to please the doctors, vote bank politics, so they did not put the medical services in the CPA 2019. So look, have a look at this. These are the services in CPA 2019. Do you find medical services here? No. So what was included here? Online, offline, e-trade, everything was included. Medical services was not included. IMA was very happy. But please understand, politicians and bureaucrats are smarter than doctors. So what they did, they just added one line, but not limited to. Fine, you come in from the back gate, and that's it, you're in. So with all surprises, this word was incorporated, medical services was removed, but not included to was added, and the doctors were directly inside the CPA. Now this 2019 CPA is very much consumer-centric and absolutely anti-doctors. Why I say that? I've just made a comparison of this compared to the 1986 version. This is very important. You need to understand this table very well. See, the good part is mediation is allowed, meaning to say out-of-court settlement is allowed except for criminal negligence. But the difficult part of it comes here, pecuniary jurisdiction, meaning to say a consumer can sue you in a district court up to 1 crore. Earlier, it was only 20 lakhs. So in a district court, you can be sued for 1 crore. The second thing is territorial jurisdiction. Please understand what does this mean. It clearly means, suppose I go to Vellore for my treatment and I'm not happy, I come back to Calcutta. In the earlier CPA 1986, the case can be registered only in Vellore, where the service was provided. But in the 2019 version, the case can be registered at the place of the consumer. So I can register a case in Calcutta. The doctors from Vellore have to come back to Calcutta and fight the case. This is no good. There's only one, sorry. So there's only one good part about it. That is video conferencing is allowed. So you can do video conferencing. The other bad part of it is, you see, you can do e-filing. So just sit online and file a complaint. You're done with it. You don't have to even pay for it. 50 rupees is the fees. So you can understand the number of consumer cases against doctors have really gone up. And this is also has been put up, false, misleading advertisement. The manufacturer, service provider, and celebrity will be caught. So if a doctor, a cosmologist starts claiming that you can have hair like Aishwarya Rai and you don't have one, you be ready for a CPA. So all those advertisements of good cars and everything, so you must be noticing now in the television that all that fair and lovely has gone. So there's no more fair and there are no more lovelies. So because there are 3 cases against fair and lovely in the CPA. So that is regarding this. Now, this is another part of the CPA 2019, which is very important. Suppose, God forbid, a case goes against you and you have been asked to pay a compensation of 1 crore at the district level. You want to appeal at the state level. 50% of 1 crore, 50 lakhs, you have to deposit in the court before the appeal can be accepted. This is again something which is against the doctors, and this you need to understand very well. So now this was the law. Now here I am trying to tell you how to free yourself. What are the ways you can prevent yourself, on what precautions you need to take in your day-to-day practice so that this does not happen to you. This is very important for you to understand. So let's analyze one by one. And now the surprises are here. Now here it is. This is a standard histopathology or a cytopathology report. For all of us here, this is just a simple report. But to tell you the truth, from the legal perspective, this is not one report. It has various components. This is one component. This is the next component, this is the next component, and this is the last component. So basically, this report, from the legal perspective, has 4 components. And as I showed you, all those laws in the beginning, your patient's lawyer is going to target you against each and every component using all the laws which I showed you earlier. So let's go one by one. So this is the first one. The first part is this, the name, the age, the ID, and all this. So basically, from where does this come from? This comes from the very fact that the patient is going and making a bill and creating an invoice. But basically, you need to understand this is not the patient's invoice. It's a service contract. We play it down very much. Now, if you go, all of us we have mobile phones and we have SIM cards in that. And when we buy a SIM card, we just use a SIM card. We don't look at this, which is a part of the SIM card, the insert. This is the terms and conditions of services which the SIM card provider is writing there, which you hardly read. So similarly, when you are trying to register a patient to your clinic, to your lab, to your basic system, this is what you issue. What do you issue? You issue an invoice come service, come receipt, which is basically to do with the patient's name, gender, the amount of money you have taken, when will you get the report, and so on and so forth. This is the service contract. And here comes the first law, where it comes to the law of contract. The Contract Act 1872 has a lot of binding to this thing. And you have to be very careful how you draft your money receipt. And basically, these are the various ways you can come into the picture. So how do you draft your money receipt? You draft your money receipt, first and foremost, invoice come receipt becomes service contract. So this is basically your service contract. This becomes the basis of the CPA. Because you're taking money, there's a service, you have to define the contract, what is in and what is out. We use the term very, very conveniently, delivery time. This is where you are mostly caught. Everybody says, the patient has a right to know when he should get his report. There's a CAT which is involved. There's a quality consciousness. There's an NABL criteria which needs to be fulfilled. Yes, you should fulfill that. Who says you should not? But basically, you change this to tentative delivery time. This is the safeguarded, legally defined word. You cannot be challenged. So the very word tentative saves you from any nuisance. The next thing which you do is you set in terms of service contract. Now you must be seeing nowadays all the big labs, they have a very big legal team. And this legal team defines the term of service. So these are the terms of services which nowadays most of the labs are using, which the patient does not read, like we don't read the SIM card terms and services. And this goes on into pages, into pages, into pages, into pages. And these terms and services include so many things, from definition to delivery, to terms of termination, to ownership, to disclaimer, limitation of liability, indemnity, privacy, so on and so forth. You can have this in the part of the money receipt, or you can just put it here. Please go to the website to see the terms and services. If ever you get in trouble with the CPA, each and every word of the term and services will come to your help. So this is exactly where we have to be very careful. Nowadays, many labs, on the reverse side of a money receipt, they print these things, condition of lab testing and reporting. Please try to use this as detailed as you can to save you from all the problems. The second part of it in this report is, so I've got 45 minutes, hang on. So second part of this is, which we use is the signation, the name. We just use it, as we feel like using it. Now let me just try to tell you, the way you use your name, you are under a legal basic criteria. The medical ethics of the NMC, the IPC criteria for using masquerading and misleading names. And then you have the Indian Medical Degree Act 1916. How many of you have read this? None, I bet. This guides you as to how you can use your name on your prescription, on your sign-out, and we have to be very careful because the complainant lawyer will try his level best to prove to the judge that this guy is a fraud. And that is where you can be into trouble. If CPA, you get away with CPA, you can get caught into CPC or maybe in the Indian Medical Degree Act. So let's go one by one. Many of us do see these prescriptions. This is just a, you can say, illustrative prescription which I've made. You have this doctor's name, you have his degrees, his designation, and his photograph. Now let's analyze this one by one. What does the Code of Medical Ethics tells you? It tells you printing of self-photograph unethical. You cannot print your photograph. You might be looking like Hema Malini, so what? So basically, the photograph goes. Next, you come to the name. This is where you need to understand. The Code of Medical Ethics, the criteria of degree 2016, and the IPC masquerading and misleading criteria have to be very, very careful. So basically, a physician shall write his name and designation in full along with registration particulars. Now, let us look at this part. You see, this gentleman's name, Dr. Syed Ahmed Javed, can be used in so many ways. Now, let's analyze which of these are correct from the regulatory point of view. Let's look at this. Yup, it's green. You can use it. Syed A. Javed is fine. S. Ahmed Javed, it's fine. S. A. Javed is fine. Till this, it's okay. And the moment you try to manipulate, mislead, masquerade, you are into IPC 420. So, Javed S.A., no. J. A. Syed, it's nowhere close to what it is, not allowed. Ahmad S.J., not allowed. Syed A.J., not allowed. So basically, this is okay, and this is not okay. So you need to know how to use your name correctly before you are into trouble. And this trouble is criminal. Next is Clause 1.4.2, physician shall display a suffix to the name only recognized medical degree, certificates, and memberships. Recognized medical degree. So basically, let's go back. Let us see this. MBBS, gold medal allowed. You can even use platinum medal if you want. MD, gold medal allowed. Member of the Indian Academy of Cytology allowed. Member of the Indian Academy of Pathology and Microbiology allowed. Cancer research allowed. Diploma in sports medicine, not recognized, not allowed. So you cannot use degrees which are not registered or recognized by NMC or by a board of recognition. So this is the first part of it. The next is, we as doctors, especially when we are young in our field, we really go crazy by using these terms. Chief pathologist, lab director. I don't know whether any one of you know the difference between the two or what exactly does this mean. And in the regulatory field, from the point of view of law, where does this stand? So a chief pathologist is a technical head without any administrative or reporting responsibility. Administrative head is the lab director. And where does the law come in? Vicarious liability. So let's look at this. A doctor is responsible not only for his negligence, but also for the negligence of his employee if such an act occurs under his direct supervision by the principle of respondent superior. And this was there in the Syed Abdul Qadir case in the Supreme Court 601 verdict. So before you use the term lab director, please understand your responsibilities before you start using that. So basically, to make you understand, the degrees are fine, the name is okay, and try to be the chief pathologist. If you want the administrative head and you know the administration well, only then become the lab administrator. Let's come to the third part. This is very important. We are so much obsessed by making the bottom line, the diagnosis. please remember from the medical legal point of view, if this is important, the footnotes are much, much more important. They are the ones which are the actual savior. They will save you. Every word which you use in the footnote is going to save you in any litigation. So be very, absolutely be very fair and very liberal in trying to use as much as footnotes you can use. You can have footnotes like this. Further evaluation, sample is likely mixed, so on and so forth. And this is very important. Invariably, it is a footnote which saves you more than the bottom line. Now we come to the fourth part, the law and science behind a judgment. How does a legal case, how is it basically, arbitrated, how it is basically, judged out, and what is the criteria? How does the judge try to give a verdict either in favor of you or against you? So basically, the law and the legal people understand lab medicine like this. Medical science is a dynamic and biologically active science, and each event is unique and has to be analyzed in context to the situation and service. This is very good for the doctors. And the next part of it is, what are the criteria of verdict? The HIS criteria. I don't know whether any of you have heard about this. The HIS criteria is very important. What is the HIS criteria? Whether harm has taken place, yes or no. What was the intent? And whether the standard operating procedure was followed, yes or no. This is very important. And here is the importance of an SOP, which people of the quality system keep on pushing onto your head. Have an SOP, have an SOP. If your SOP is in place, your intention is good, you are saved. So basically, if you try to look at the lab ethical guidelines set up by the WHO, you will realize that basically, right to decline an examined specimen and best possible analytical result to the patient. Best possible. This is very important. You are not bound to give a particular value. You have to give the best possible result. So let's look at it. This is a standard biochemistry report, which we all see, which we are so much used to. My question to you is, where is it written that the report has to be like this? Nowhere. We have been following one to the other. But from the legal point of view, you have to understand, we have to give the best possible report wherever possible to safeguard ourselves. So the science behind this, as it is being argued in the court of law, is basically twofold. Metabolically static analyte, metabolically dynamic analyte. So what are the static analytes? All viral and bacterial markers, serological markers, surface markers, things which are unlikely to change in a very short span of time. It can change, but say somebody is pregnant today, cannot be not pregnant tomorrow. It's very unlikely. So basically, these are static analytes. Now you have the dynamic analytes, like blood sugar, electrolytes. They keep changing every minute, every hour. So for each one of them, the legal way of handling is completely different. So what is the legal standing? For all metabolically static analyte, you have to have a detailed formatting protocol like this. Like you have a lot of detailing, like which we all do. We have to write what is the sensitivity, what is the specificity, what are the ways this can be false positive, false negative. The more you write, the more you are in a safeguarded position, irrespective of what the result comes out to be. So we can go along and see, these are the various ways you can detail out things. For metabolically dynamic analytes, the ones which are dynamic like blood sugar, electrolyte, and all these things, review of result, organized IQC, ECAS, and personalized and exhaustive comments. These are the ones which you have to present in front of the court of law to safeguard yourself. And the most important, which we all invariably miss out, is text reporting. You need to learn how to do text reporting for numerical values. I will show you how it works. So basically, review of result, I think we all know about it. We check the QC, we see the delta check, we see the TRF. We should have a very well organized IQC and ECAS. You have a quality plan. I'm not going into all these details. Personalized and exhaustive comments. This is very important. You have all these predefined comments. You can see here. This is the major savior. This is the take home for the day. Text reporting. Wherever in trouble, resort to text reporting. What is text reporting? Let me show you. So this is a report in my lab. A lady has undergone an LHFSS prolactin test. So you can see in the prolactin report I've written here, see text report below. I have not put a numerical value. Nobody can tell me to put a numerical value right there. What is the text report? Let's have a look at that. See, the value of prolactin is 365. So basically, what I've done is I've given a text report. The value obtained from serum analysis of prolactin is 365 against a biological reference of 4 to 15. This value is abnormally high. On internal data delta check, no records of previous analysis was available. We also tried getting in touch with the referring doctor, but failed to contact her. As the IQC are in 1 SD scale, the result has been validated with caution. Aberrant prolactin results are reported in literature. If the value does not correlate with clinical findings, a repeat analysis is suggested. So exhaustive. So this is exactly what you should resort to when you get aberrant reports, rather than just giving a number and getting away with it. Similarly, here in blood group, we can give a text report in detail. Now we come to the issue of amended reports. Many a times you will find you have released a wrong report. That could be a typographical error. Your typist was sleeping and he typed something like sodium 2.5 and potassium 140. Just the reverse. And the report has gone to the patient. And the patient calls you up and says, what is this? The legal standing of this has to be understood. See, basically, you have a SOP, which is very well defined. How do you handle revised report, amended report? You know, people are here who are experts. They will tell you in much detail. You have to have a system, a trail, a protocol. But from the legal point of view, what do I say? Release of revised report from the legal point of view. Should we ask the previously released report from the patient? What do you say? Should we ask the patient to give the report back? Yes or no? Yes. No. The legal point of view is not required. It's not important. The report has been given, it's been given. What you need to do is you need to do the correction. So what is the correction? It is important to release the revised report in a medium which is accountable in time and logistics. So how do you do that? You email a fresh report. You WhatsApp a fresh report. So much so that you have a record as to when this report was given to the patient, in the timeline, whether any harm was done or not. And that is very important. And the report should carry this as a very important line. This is the final report and supersedes all previous report. Please disregard previous issued report. Random error is process related and is sincerely regretted. This is the major savior. So timeline and logistics and these statements help you a lot. Referral lab protocol. You know, in my NABL audits, this is one area where I invariably try to raise a non-compliance if it is not adhered to for the safeguard of the lab. Because we take it very lightly. We are not doing a test, we are sending it outside. Fair enough. Remember, you are under the liability of the Contract Act Integrity Pact. This is very important. Transparency is to be very clear. The patient has come to you, you are doing it somewhere else, the patient should know that it is being done by somebody else. This is important. Otherwise, the patient can sue you under this act, integrity issues, non-transparent. So basically what you do is, you have in your money receipt or service contract, mention it clearly, outsourced to referral lab. In your final report, this special test has been done by a referral lab. Even if you want to name the lab, you can name it. If you don't want to name the lab, you cannot name it. But legally, now you are correct. You are under the concept of integrity of the Contract Act. This is important. The provocative peer. Let me tell you, in my more than 30 years of experience, it is your friend next door, your colleague, who is the one who is going to instigate a CPA for you. If there is 100 CPA, 95% of them has been instigated by a fake friend. He is the one, your doctor friend is the one who's going to instigate you. So I would request all of you here, do not do this instigative business. What goes up will come down. What you sow, so shall you reap. Let's not do this. Stop this. You should be very, very nice. If there's an issue, fair enough. I will just share with you a practical real life experience. A review of slide. Whenever a slide review comes to a person, he starts behaving as arrogant as this man. He feels, now I've got a chance to set the score right. I'm going to get this right, this guy into my knuckle. So I'll show you exactly how things happen. In the Supreme Court judgment and the CPA, it was very clear. By applying the same test as is applied in the action of damages for negligence. But it never happens. You don't apply the same set of tests in a review. What happens in the general review is this. For example, this is a 36-year-old female who undergoes a lung FNAC. History given, fever 1 month, hemoptysis. This is the history. FNAC is done. This is what you see. For all those who understand cytology, these are normal cells, these are inflammatory cells, and some bad-looking cells here. Similarly here, normal-looking cells and some bad-looking cells here. And same is the case here, some bad-looking cells here and inflammatory cells. So this poor cytologist, with this limited history of a 36-year-old lady, gives this opinion. Inflammatory region with dysplastic change of the bronchial epithelium. Perfectly fine. Where is the problem? This is all what she had, this is all what she knew, and this is all what she reported. It was reviewed by another person. The moment he was sent the review slide, everything started coming out. The second opinion, comes the history. The second opinion pathologist is being shown the CT scan report as well as the brain MR. So you got a brain met, you got a CT scan lung lesion, and everything is very clear. So this guy comfortably just gives a one-line report, moderately differentiated squamous cell carcinoma. Pulls his collar up and says that, see, I am good, he's bad. This is something which we should not do. Basically, we need to understand that. Basically, humility is the call of the day. Try to be humble, try to be modest, don't try to settle your scores by using the patient as the medium. I'm not going to go into this because we are running short of time. Neither am I going to talk about this some other time. Who can sign a lab report? So basically, what I'm trying to make you understand is, before you sign out of the report, be careful, be cautious, and be totally composed. Use correct terminologies with the report, your designation, use the money receipt as per the contractual act. The good part of the story is, out of 100 patients who are unsatisfied, it is only 1.5% who will go for the filing of claim. Out of that, only 0.1% will go to the level of trial. 0.001% will get a verdict. And out of that, 0.0001% will be a verdict against you. So bottom line is, for all of you understand Urdu or Hindi, गिरते हैं शह सवारी मैदान जंग में, वो तिफल क्या गिरे जो घुटनों के बल चढ़े. So don't be afraid of riding just because you're going to fall. Ride carefully and enjoy the ride. So that's it. So basically the best insurance policy is care, concern, and consideration. Like the famous Dr. K.C. Mahajan said, faith is the only currency between doctor and patient. I wish you best of luck. Thank you so much for the patient hearing. Eid Mubarak.
Thank you, sir. As usual, it was excellent. And I think it was quite riveting because for once, nobody fell asleep. So it was a great job. So thank you, sir. For our next session will be an open session, which will be conducted by Mr. Pankaj Johri, Director Medical of NABL. So I request Mr. Johri to please come up on stage.
So we need to take the questions later.
Yes, and the same session, sir, medical legal segment only. This will continue. So please wait after that, then there's a felicitation. So if you can please come and take over. Thank you, sir.
So it's a very good evening, and I'm saying lot of thanks to Dr. Nadeem. He kept everybody awake, and extreme appreciation for him actually. That he tried to alert the doctors and basically the professional who are present here from the medical laboratories and the signatories and the quality manager, technical head, lab director, whatever terms he has used, for all these fellows who can be that doing unknowingly or knowingly the things that what can be the medical legal, I mean some legal, not medical, but legal implications of all these things. So thank you, Dr. Nadeem, for your extremely and well-crafted presentation and this awareness also. One thing which I have got from Dr. Nadeem presentation is that I think now that all these things on NABL 216 and the use of NABL 133 also, that medical accredited laboratories, which were giving us presentation, representation, and submitting so many things to us that why we can't use this in that way, why we can't use in this symbol in that way, and why can't other signatory can sign, and why this name can be used in that way. So all these things should come to a rest with this kind of good presentation, that what can be the legal implications of this. So starting, I would like to give, because it is a very feeble attendance, so would not like to take much time of you. Would like to divide my presentation into two parts. One is the updates about NABL, so that the accredited laboratory definitely have a benefits of coming here. And secondly, that about the legal implication also, that what Dr. Nadeem has told, continuing from that part. So continuing from Dr. Nadeem presentation, you see that why a legal NABL is asking you to, for a proper name, to mention the exact name of the laboratories in the application form, exact address, and the correct legal identity and entity now, which we are using the term, and the linkages, that organogram in the organogram we are asking. So now you can understand that when NABL policy has been conceptualized and implemented in that particular way, that we are asking the laboratory to furnish the exactly correct information, and when the dealing officer is contacting the laboratory, oh, this is correct, this spelling is correct, this extra S is there, this comma is there, this city number is there. Why it is so? Because there can be the legal implication for this thing. Until only the things are going good, it is good. But one times when somebody is, bringing the laboratory in the court, or then it is very difficult. I'm just, recalling our incidents. I appeared on behalf of NABL in a case. It is a criminal case, and that case was of 376, section 376. And it was from the forensic laboratories reports. The defense lawyer has very, tactfully pointed out to the laboratory, to the judge, to the court, that the date on which a report has been generated by this forensic laboratory, probably not having the accreditation. At that time, it was not accredited. So when we are hearing this, it could appear to anybody, okay, then what? The point was that laboratory missed the continuation of accreditation by a few days only. And they did not bother to maintain the continuity. The government lawyer, government leader, his plea was that it is a process only. And laboratory has submitted, of course, and time was given to NABL also, time was given to the forensic lab also to submit their explanation in the next date. They told that it is a process only, a laboratory has submitted the application, and because it was a due process, this delay was there, and something this and that, and how does it matter? The process is same, the equipment are same, the personals are same, the quality management system is same, the address is changed, there is nothing changed in the process. So how a report, generated with a accredited body symbol can make a difference on the test report, and how a defense lawyer can, can say about that this is an important aspect. But the judge told it, no. You have taken accreditation, it means it has some value, it has added to your system, and we can have a trust and confidence in it. For whatever reasons, your accreditation is not there. The argument by the defense has some weightage. So we need to send the sample to another accredited laboratory and get the results for retesting to be done by other accredited laboratory. So I don't want to discuss about the outcome of the judgment, but the point is, such small flaws, small procedural lapses, or carelessness by the laboratory management or the quality manager to maintain the continuity of accreditation can also pose a legal challenges to the laboratory. Though it was a case of a government laboratory, what I'm talking about, it's a forensic laboratory, but same thing can come to a medical laboratory, private laboratories also, or other laboratory, biochemistry, or other laboratory, or any type of laboratory, because like Dr. Nadeem has told, it is very clear that civil negligence, the criminal negligence, and the contributory negligence, these three kinds of negligence are the major part of the medico-legal negligence in a medical laboratories, and defense or other side can very well take advantage of the lapses of your flaws in your system, which you have inadvertently probably done it. So that is why NABL is very keen in conveying the laboratory. Please submit your application in time, your renewal application in time, and you maintain the continuity, because you do not know that one day, 2 days, or few weeks, or few months, how much losses in terms of that reputation and the finances and in terms of operations can come to the laboratories. So this is the thing, and I think that NABL 216 is, though people may think that it is a kind of a villain, adverse action. We are talking about adverse action, but it is a deterrent. Deterrent to for a laboratory to avoid some wrongdoings. So it is in that form. Like all other policies, like 133, when we say that use NABL symbol in that way, use NABL symbol in that way, that combination of markup with some other things, all because has been crafted, all have been brought into the policy after consultation with the legal team. So this is very important for all the accredited laboratory personnel whosoever are sitting here to understand that these things have not come suddenly. They have come after due consultation. And you're taking advice of the experts, all this thing. Now, if you see all these things, what Dr. Nadeem has told in medical legal aspect and legal implication also, ISO 15189 is so beautifully taking care of all these things. Like HIS, he told that harm, intention, and the SOP. So if you see the harm where he was saying how much less or more harm is there, what harm is there? Of course, the review of the report is very important. Through that procedure, through that process, you are taking care of very important aspects and the harm part. Then the risk management, risk assessment and the mitigation, the outliers, then the root cause analysis. So all these things are making you aware about the harm has been caused, has been done, and how you can take care of it. Intent, what he told, 15189 or any conformity assessment standard, as such is talking about three things only. And these three things are, one is the impartiality, second is the confidentiality, and third is the consistency or consistent operation of a medical laboratory or any laboratory which is undergoing a conformity assessment. So intent part is covered under impartiality. If you are having an impartiality policy and you are running your laboratory operation impartially and you are demonstrating impartiality in your operations, in your system, your intent is there. And once again, the intent is being demonstrated when you demonstrate the quality policy and quality objectives also. So this is intent. Now, SOP, you all know, NABL is always asking you to have a proper SOP for each and everything. Even at those places also where a SOP is usually not asked in the standard. Even then we say, or our assessor are saying you, it is good if you have SOP for doing even that activity. Why it's so? Because they are protecting you, they are guiding you. A person X coming or going, in place of that another person is coming, but SOP will be there. So what I am saying is about the standard. In place of me, somebody else will come. He will also talk about the same thing, that uniformity and harmonization. It would be there. So all these three things, HIS, what he told, this 15189 is taking care. The report content, who can be the signatory when we are giving you any decision letters, that a laboratory has to abide by the national laws, by the regulations. We have mean those things only, that you have to check what kind of rules are existing in the country, and you have to abide by this. Which are explained, which are mentioned in the ISO 15189. And from this sentence itself, I would try to move into my second part, which I told about updates about NABL. So that NABL 112, in that second edition of the LabCon, CAHO LabCon Hyderabad, I have announced it, I think I told from the dais, that we would be working on NABL 112, and we would soon be coming with the 112 edition, which would be as per the requirement of the ISO 15189-2022. So obviously, those who were present there in Hyderabad and have spoken to me, they have a valid question to me. It is almost an year. So when did you start the work, and why it is late, and why it has not been uploaded on that, on the website? So the reason is, obvious reason, that we are discussing each and everything we are discussing in the context of those implications. You would find many changes this time in NABL 112. Some changes may be surprise, some changes may be your expectations, and some changes may be I mean, something which you are asking, which asking the laboratory to do something more. And some which have been that, okay, these things have gone. So finally, this thing which was, troubling the laboratories for many years now, this thing is not there. So it is due, it has been drafted. And the final draft is almost ready. I would say, when I'm saying almost, you can also, write off the word almost, it is ready. I hope that it would be uploaded on NAVL website probably next week, or when I will go back from CAHOCON. After that, it has some good changes. And I would request every stakeholder to please go through the NAVL 112 and put up the comments. It would be there on the website for a short time, but we expect to receive the quality comments on NAVL, 112. So this is 112. Second is that transition part. So transition of medical laboratory from 2012 version to 2022 is in progress. Many laboratories have have adopted it. I mean, they have given us option that when they want to be, because this time we have left it to the laboratory. But now we are thinking that we should not leave it no more to the option or to the mood of the laboratory. We are going to circulate a format to the medical laboratory very soon, and we are going to ask that when is your plan for converting to the 2022 version. The main reason being is NAVL will stop accepting application for 2012 from 1st July 2024. Okay. So for the first fresh application. So 30 June 2024 is the last date as such. So it means those laboratories, we have it is now very short of time for us, it means. Only few months are there. So this is one reason that why we are now in alert mode. We expect all laboratories to come very quickly for that and to implement their system. Otherwise, also for those laboratories where the desktop assessment is there, is due, those who are having surveillance, they should not have any problem. What we are asking the laboratory, you convert to the 2022 version, you get transition to 2022 version on your immediate next activity. Whatever next activity is coming up, you take the transition. If you are not taking the transition, probably it is going for the loss of the laboratory, because in that case, a special assessment has to be planned for the laboratory, and then it would be a full assessment again. I mean, so it is an additional assessment maybe there for the laboratories. So this is the second update. Third thing is that the assessor training course, which we have not done for last 2 years, perhaps. Which we have not done it because we were for the 2022 version, and there was no point that we go for the assessor training or 2012 and then again doing a refresher course for 2022. So now it is again, we are going to do it again, starting it, and very soon, probably in the next month or after that, we are going to start it. So those laboratory personnel or those doctors or those, who are, very enthusiastic, and they were contacting NABL, contacting me many times that we want to. They have an opportunity this time because a lot of rush is there. So all good people may come and may register themselves at NABL portal or can send their CV to the training cells. This is the third information. Fourth information is that on the portal, updates are there. Many changes we have done in the portal. I now hope that the portal is smooth now, I think. And the labs, instead of writing, fulfilling the scope manually, they have the option of uploading the work scope. Excel sheet, they can upload of the scope, of the equipment and other reference and all these things where you previously supposed to be fill all these details. Now you can make a Excel and you can upload it. So this is also a good changes. NABL has done it for the facilitation of the labs. Another idea which I want to float it in front of you. That what if we can do kind of a for the international call, so I just cut it like that. So what if we can make kind of a codification of the test parameters? How is your feel? How is your opinion? If a kind of a lab codification, not lab codification, the parameters codification is done, and it is to you. It mean lab to pick only those that yes or no we want to go for this parameter with this test method, something like that. So it is making easier for the laboratory. Just an idea, I'm just throwing it up. So please, submit your feedback, your comments on this, whether your laboratory is following a method which is distinct from the other laboratory, because in medical laboratory, this is not all are following the same kind of the methodology almost. The parameters name may be little different. So if kind of a harmonization and if it can be done by making a test parameter form in the coding forms. So this is the another idea which I want to float in this way and want to have your comments and suggestion on this. So with this, thank you very much, and don't want to take much time because already it is this is 6:10. So thank you so much. Okay, thank you.
Got a few questions for you.
Okay, can I go?
Yeah.
Okay, thank you.
So you can take a seat here also. There's a mic.
Yeah.
Okay.
Dr. Nadeem, let's call him. Dr. Nadeem?
I'll just.
Yeah.
Dr. Nadeem, can you please come up on stage? So please take a seat. So please.
Yeah. Please take a seat, yeah. Yeah, sit, sit. Yeah. So I must thank Dr. Nadeem for a very lucid and comprehensive talk. I mean, we have really gained much out of it. And but I still have a couple of questions. That I know you and you know me, so that's how we go. One is regarding the POCT. No, yeah, one is I hope I'm audible. Yeah. One is regarding the point of care test that we are doing, which is now a part of the NABL 2022. The responsibility, the ultimate responsibility rests with the lab director. The tests are done in the ward. The ward sisters, the full nursing staff are not under the purview or the jurisdiction of the lab director. But still the lab director has got a vicarious responsibility. So the lab director has got a vicarious responsibility. I mean, why should this be? this is my simple question. Let me just complete. This is the first one. The second is, technology has gone so much that the requisition forms, they are filled at the billing counter. About a decade back, I had a senior gentleman coming to my chamber and saying, कि हमार boyish की 3 बछर लगे. Do you think I am a 3-year-old boy? I said, no, sir, definitely not. So he showed me his report. I'm basically a microbiologist, so he had a urine culture report. He also had a CBC report. Now the age was 3 years. Luckily, for microbiology, there was no growth, so I could manage. But then, for the CBC, the report, the reference range was given of a 3-year-old. See, the lab has only received that specimen. The test was done on that specimen. Now, obviously there's a difference between the reference range of a 3-year-old and, a 60-year-old. So my question is that where are we legally? Where is that doctor who has signed on that report? What is his, the legal aspect to that? Sir, Mr. Jory, sir, yeah. So NABL, what I personally feel, unlike the CAP, I have a lab. I just do blood sugar, cholesterol, urea, creatinine, that's it. And I sign it is an NABL lab. To the outside world, my lab has got that standard of an NABL lab, where only I'm doing, say, about 10 or 15 tests. That was one. Second is regarding the interlab comparison. What I understand till date is that one lab is sufficient, sir? One lab is sufficient now? Because I really don't know, because I'll come to my next question. So even I think a couple of years back, or till the 2012 was there, we knew that one lab was sufficient for an interlab comparison. Now I got a CRP of 30. I send it for a interlab, the report comes 90. So my lab is wrong. I am an NABL accredited lab. I send it to a lab for an ILC. My report is 30. They send a report of 90. My management tells me that you're no good. Now what happens? Another lab, they send their ILC to me. Now this case, I am the reference lab. And then so now what has happened? My lab, which is wrong, becomes a reference lab. And the third lab which sends it to me, that may be right. But now that is wrong because, I'm the reference lab. You understand what I'm saying? Okay. The next is, sir, regarding, the transparency, NABL SSLs. Now, is there an age limit for NABL SSLs? Yes or no? If it is there, I would just like to know that, where is it? No one just about knows what it is. That's about all. Sorry? Upper age.
To become NABL assessor, there is of course a age limit, and we have a criteria in our NABL website. It is there. What is the age limit on which NABL some person can apply to become assessor?
No, I am asking what is the age limit beyond which assessments?
Yes, there are, but it is not kind of a, some kind of a blind something. See, assessment is not kind of those area where you can simply put down the shutter. If you have a person who is having a tremendous expertise and a subject knowledge, and where we can use that expertise for an assessment of a specific area, a special area, we definitely would like to use that expertise. But in general, because the fields are open, many persons are there, and a general assessment kind of things are there. Obviously, there are to be some policies, some cutoff criteria, where NABL decides what can be. who can be sent and who can.
Is there a specific criteria, sir? This is my
No,
specific question.
I understand it. I've given you that answer. That if a specific, special kind of a assessment is there and you need that, definitely we have to. But of course, there has to be. You have to put, you have to draw a line somewhere.
Absolutely, sir. My only humble submission is that, in any service, government service, there's the age of retirement, say 60, 58, 62, 65 for professors, whatever is there. And beyond that, obviously, if they are so knowledgeable, they are taken in on a special case. But then I think NABL should be a bit more transparent. And if they say that there is a particular age after, because I have seen assessors who have been doing assessments, when they reach a particular age, they've been doing assessment after assessment with no, repercussion and good assessors. But suddenly after a certain age, the whole thing stops. Yeah, I'm not, debating beyond this.
No, it's not debatable. All points when in an open house, we sit in an open house with an open heart. And nothing is taken as a criticism or a, negative things. All things are taken with open arms. And it's a good point for us. It's a good feedback for us. But, let me tell you one important thing is NABL is an organization which is working as per ISO IC 17011 standard. It is peer evaluated every 4 years. There are many others also. But in our 8th evaluation also, this completed in February 2024, continuous 8th evaluation every 4 yearly. NABL probably is the only accreditation body in the world which has not got any non-conformances in the 8th evaluation. So good. The point which I want to make here from the dais is that there are bodies and there are experts who come and who see the report, our policies, our procedure, our criteria, and they check it, whether this accreditation body is complying to the requirement or not. Even if it is 99%, is definitely there would be an NC.
I understand.
So you can take it that we are nearly or at 100% actually.
Sir, there is no denial of the fact
Now,
of what you are saying.
coming to the second part. So this is the one thing which is the example that an external things, what is are there, some things are there which are coming here. Now, second thing is NABL has an internal mechanism like any other organization. We have our internal mechanisms. Assessor monitoring cells are there, all these things there. And each and every, though I need not to discuss all these things, but because you talked about the transparency part, each and every assessment report is evaluated stringently on every parameters. They are parameters. Assessors are also judged on the parameters continuously for every evaluation, each and every evaluation. So I want to assure everyone present here that there is a mechanism through which NABL comply to the strict requirement of how you should do how NABL should do an assessment. This is, and NABL maintains a full transparency also in that way that there are some documents which are in public domain. You can come and you can see that. There are internal things also which for every organization has, because this is a policy decision that on what basis we are taking, the feedbacks are there. So feedbacks cannot be made open to everyone. Things are there. Things I want to assure you, sir, these things are very well in place.
So far, so good, sir. Thank you.
Thank you, sir. Thank you.
Dr. Nadeem,
Yeah, other points, yes.
Oh, it's
Other points you asked. One is about, you ask about POCT part.
Yeah.
So POCT, yes, it has been taken into the 2022 standard by the ISO clearly, and for that the other standard has been withdrawn. The other standard which was explicitly for POCT, that has been withdrawn now. So POCT is in 2022 versions. The responsibility, you see that POCT is not a domain which can exclusively be taken by a laboratory. This is for sure. Okay. In a hospital setup, this is a multidisciplinary or multi-domain approach where the other department of the hospitals are necessarily to be engaged in the POCT.
Absolutely.
That you agree?
Agreed, fully, completely.
Fully agree.
Complete.
Now, so standard itself is talking about that if a laboratory is doing the POCT, is involved in the POCT, then how it has to be carried out. There is an annexure exclusively on the POCT that there has to be a multidisciplinary committee, a multidisciplinary approach where the concerned persons of other disciplines have to be part of that. And laboratory director, laboratory has to be there, but onus has to be taken by somebody. So onus is taken by the laboratory director, suppose within they are declaring it manual. It is after thorough consultation and thorough collaboration with the other discipline, complying to the requirement of those domains as well as to the quality management system of their own laboratory. This is a POCT.
No, sir.
ILC part you are saying.
No, this point
Okay.
is still not over, sir. See, the responsibility, again, see, what Dr. Nadeem said, where are we legally, where is the system?
Legal-
NPL is fine, sir. See, then what I feel is then the responsibility instead of the lab director should be given to the higher management, under whom the sisters and the whole nursing staff, the biomedical staff, there is much to it. That instruments calibration is under the biomedical department.
We
Sir,
need
why
to-
I'm talking,
We
sir,
need to understand the accreditation system first. When a laboratory, whether it is a standalone laboratory or a laboratory under hospital setup, when it is applying to
No,
NABL.
sir, standalone lab will, let me cut you short, sir. Standalone lab will not do a point of care testing.
No,
You have to have a point, no, sir.
I'm trying to make a accreditation system here. So when it is applying to accreditation, for accreditation to NABL, it itself is a entity which can take its own decision. The standard is very clear. NABL does not make its own standard anything else, like any other thing. We have the standard, ISO 15189 is there. We have our own policy procedure, which have been made after the due consultation with the laboratory, with the legal expert, and only then it has been. Anyway, it is a matter of long debate. Now, third point, your ILC part. ILC part is, though standard is allowing you, once again, you are right. Standard is allowing you with the comparison with the one laboratory. But for the statistical part, it is very clear with as many as laboratory you would take part in the inter-laboratory comparison, you would reach to a true conclusion. Because your Z value, your that will be precise, more accurate. Otherwise, it is a one-to-one comparison where Z value may be very high, I mean.
Sir, exactly, because here we are studying, the topic is medico-legal liabilities. So, so I am
about ILC.
Yeah, so, so that is why, I mean, with all due respect to everyone in this hall, but I am still not satisfied with this, both with the POCT, because there is still a vicarious responsibility, which I have just heard, and the ILC, which I told you, I leave it to the audience and to you, sir. I mean, if you can do something, but I still feel, and let me tell you one thing, that if I am feeling this, there are others who are feeling this. I have been an NABL assessor. I have been a technical assessor and a lead assessor, and I've got a few more questions which I don't want to give it now. So let's close it at this. Thank you so much.
You put up a slide regarding chief pathologists as well as the lab director. The question is related to that. Now, what is the liability for litigations when you term an individual a consultant? for the lab reports. Chief pathologist and the lab director, you mentioned that was quite clear. But the probability of litigations when you give a terminology as a consultant.
The question is, what is the legal liability of the terminology consultant? Is that right? Yeah. Legally, anybody giving any consultation, whether verbal or in writing, is a consultant. You are claiming yourself to be a consultant. It has no value on the legal perspective, whether you write there consultant or not consultant. It has no value. But the moment you use terminologies which has vicarious liabilities under the Contractual Act, that consultant has no vicarious liability, so it has no legal implication.
In the same scanned report, sir, the report which you showed earlier, there was a scanned and copied signature, a copy pasted signature. Now they call it a digital signature, and you and I know that that is not what a digital signature is. So what is the legality behind a scanned and copy pasted signature and the original digital signature?
I didn't want to move into that subject. If you must have seen, I had said who can sign the report. If you don't mind, I don't want to answer that. It's a huge topic. I can answer that. I've got all the requisite material. It is a very controversial topic. It's a very controversial topic. If you really want to understand the actual legal standing, digital signature is not legally valid. Please understand that. Everybody is using it. But as per the law of the land, NMC, MCI earlier, digital signature is not valid. But when this was asked on an RTI, this was asked through an RTI, it was not answered. So basically, it's something which everybody wants to keep quiet. Nobody wants to deal with it. So this is it. I mean, digital signature, whether it is facsimile, or it is pure digital, or it is copy-paste, it's not valid. It's not allowed.
Because earlier we had a speaker presenting on her automated lab, and she said that the final reports are automatically pushed because it is already validated. Now, how is that validated when it does not have the signature?
Auto verification, you mean?
Exactly.
You mean auto verification?
How is that different?
It's different. Should I answer that? See, I'll explain it to you. Auto verification. See, let me explain you one thing. The legal standing as regards Supreme Court's judgment, NMC, as well as the protocol which has been set up by the Clinical Establishment Central Act is very clear. The lab report has to be signed by the person within the premises, whether it is physical or digital. So auto verification is taking place at the premises. It is being done auto-verified, signed out, but the person whose signature is being used we are presuming that that person is physically present there. It's fine. It's perfectly fine. But this is very controversial. It's very controversial. It is going to change very soon. I'm telling you, it's in the making. Any other question?
Thank you. Thank you so much. So we come to the end of this very interesting session. So can I now request Dr. Ranjan Mukherjee to please felicitate our chairpersons and speakers for this session? Can I please request Colonel Dr. Taposh Roy to come up? Thank you. So can I request Dr. Nadeem to please come up on stage? He's already there, but come forward. Thank you. And Mr. Pankaj Johri, sir, please. Thank you. We now come to the end of the scientific program of the third CAHO LabCon 2024. So I think we are ready for the valedictory and the vote of thanks session. So can I please request Dr. Shusrut Sen? Okay, so we'll take a 5 minutes break, but it's a gentle request not to disperse because the vote of thanks is still left. So if we manage so far, I think we can stay for a few more minutes. Yes. I think we've all had a lot of question and answers, so we can do without your questions, I think, for the time being. Rest of the questions you address over the banquet. So once the hall, 2 people come in, we'll have the vote of thanks. So honest request to the audience to please remain seated till then. Although that's a tough call, but still.
Yeah, sure.
Excuse me, all of you.
Take this.
We are waiting for hall 2 to assemble here. Meanwhile, at the end of the day, can we have, since we believe in feedbacks, can we have a bit of feedback from our participants, delegates, maybe speakers?
Ask from the organizing chairperson. He wants to ask questions and let him give a feedback.
Okay. Feedback to us, his team.
He'll give a feedback on himself only, I guess. You want to give a feedback? You want to give any feedback?
Would you be interested in giving a feedback till hall 2 assembles here? Then give. The mic is with you.
We are all here, sir. Please go ahead.
Now, what do you mean by feedback? Everything is closed, the speaker's gone. After that, you are saying feedback. So maximum I can take feedback of this program from the audience. So I think there are only a few people here. So let's assemble in hall 2 and end the session in hall 2. Because the hall 2 is 10 minutes still to go. So by this time, have a cup of coffee and assemble in hall 2, please. So we'll do the end of session in hall 2.
Is the seat loaded in hall 2? What of that? Speech মানে যেটা vote of thanks যেটা দেবে সেটা hall 2 তে loaded আছে? Hall 2 তে loaded আছে? It's like
প্রফিট ফেলে গেছে পুরো ব্যাপারটা হ্যাঁ আরে না